Okay, and we'll use the clock, right? Good morning. Welcome to the final day of the 12th Annual Cayman Islands Healthcare Conference. If you're joining us for the first time, my name is Ben Mead, your host for this final session of today. Now, it's been a fantastic couple of days already with some informative and useful information being presented and shared. Those of you who are here in person, here's hoping that you had a chance to eat before we get started. After all, breakfast is the most important meal of the day. We've all heard that since we were children. And same to you viewing at home or at work. I want to say thank you again to our sponsors, Health City Cayman Islands, Doctors Hospital, Integra Healthcare, the Cayman Islands Health Services Authority, Astor Cayman Med City, Kelly Holding Events and Communications, DART, Compass Media, and Cineco. Our first speaker today is Dr. Edward Fitzgerald. He's joining us from Bermuda. He'll do so virtually. Dr. Fitzgerald is the head of healthcare for KPMG in Bermuda. He will be sharing global lessons for recovery and resilience in healthcare. Dr. Fitzgerald, thanks for joining us. I now hand over to you.
Well, thank you so much, and thank you again for the invitation to join you this morning. I'm speaking to you from Somerset in Bermuda, and really pleased to be able to join the conference for the first time. And as the host introduced, my name is Ed Fitzgerald. I head up healthcare for KPMG across our island group, which I'll explain a little bit more about shortly. But I'm really pleased to be able to share with you some global reflections, some perspective, some learning and lessons about how healthcare systems are really starting to confront some of the challenges and the changing nature of healthcare on the back of the COVID pandemic. So in the next 40 minutes, I'll be sharing some of these lessons with you and certainly a bit of time for questions at the end. So I really hope this will stimulate some discussion and make some interesting points and learning for you. Now, just by way of introduction, I haven't had the good fortune to meet many of you, although I've spoken to some of the healthcare stakeholders in Cayman, so just wanted to take a minute to introduce myself. I'm based, as I say, in Bermuda. I've been working here for nearly a couple of years now, and actually lead our healthcare work across the islands in the region, and additionally globally, recognising some of the specific challenges that face island healthcare, and a lot of learning to be shared on that front as well. I'm actually a medical doctor by background. I spent nearly 20 years in practice and also working in global health. I've had a real good fortune through KPMG to work in over 30 countries now, so had a fantastic opportunity to look at the many common and also unique and different challenges that are facing healthcare. And that was, of course, mainly pre-pandemic when we were still able to travel. And I am, I confess, a reformed academic as well. Many of my younger years were looking at some of the technical elements of working around healthcare, particularly in surgery, which was my field of practice before stepping into health practice management. So I do look at some of these things through that lens as well, which helps add a bit of extra information and detail. So I hope that provides a little bit of background and introduction on me. And I mentioned island healthcare, and the other point I just want to share by way of introduction, I think many people quite rightly see KPMG as an accountancy company, and I often get asked why am I working in healthcare in KPMG, and it's perhaps not as well known as it should be that we have a very substantial global healthcare practice spanning 46 countries across the world, and we provide advisory services as well as the traditional tax and accounting areas in healthcare. And so my work is in advisory, and I've been fortunate to be involved in many of the projects listed here, because I think as well as it being little known that we have a great interest in healthcare work, within that we have a specific interest in islands. And you can see here listed some of the wide range of projects right across the world that we've been involved in. So I think it is safe to say we have a good understanding of some of the unique problems and challenges in island healthcare, which I think are actually also huge opportunities. I am very interested and excited by the potential for improving healthcare in islands. I think it has a lot of strengths to be built upon. And I'll bring some of those island perspectives into play as I walk through the global lessons that I'm going to share with you today. So with that said, this is some of the specific coronavirus related work that's led to those global learnings and lessons. There've been many more projects than you can well imagine, many more projects around this area over the last 20 months or so now. But these just flag some of the major global projects that we're proud to have been involved in and supported. I'll pick just one or two of them out, but perhaps the most well-known in these is I was in Bermuda, and I woke up one weekend morning in March last year to a message from our then global head of healthcare asking to help build a multi-thousand bedded hospital facility in London. And that was Friday, Saturday morning. The hospital was required by Friday that week. And that became NHS Nightingale, one of the largest projects we've been involved in globally, and that we're very proud to have helped support. But you can see here quite a range of other projects where we have been able to bring all of our team and learning experience to really specifically help deal with coronavirus related problems. And we've rolled our sleeves up and we've really got involved. And you can see bottom left there, at that time, the work that I was involved in supporting the hospital and health system in Bermuda as we first started to react to the challenges facing us. So that's really the learning that's helped give the background to all of this, and our observations about how health systems are changing and need to change. And actually, although there are many challenges that have been faced through COVID-19 throughout the world, the point that I really want to make to you this morning is that actually there are a lot of opportunities coming out of this. I think many of us will recognise some of the problems that healthcare faced globally going into the pandemic. And actually, coronavirus looked at a different way. Although it's been an immense challenge, it also becomes the strongest catalyst in a generation for delivering some of the change and improvement that has really been needed in healthcare for some time. And so I look at this in a very positive light of the opportunities that are there for us to think about and focus on some of those points that really do need to be developed and taken forward. So in terms of background context, thinking pre-pandemic, it's not that healthcare wasn't facing problems. They have really just had a bright light shone on them by the pandemic globally. And as we stepped into the pandemic, these were some of the problems that were already facing us, that were already well acknowledged, that have already been touched on in other elements of the conference so far over the past few days. And this really takes a global picture. Many of you will be familiar with some of the island-specific elements of these issues. But globally, we face an aging population. The dependency ratio is changing, and you'll be well aware that that then brings in a changing nature of healthcare. Perhaps the biggest and most fundamental for me is that if we step back 60, 70, 80 years, we started to build health systems regionally, nationally, globally, that were able to tackle acute episodic disease. And fundamentally, the nature of healthcare has changed, and coronavirus has really shone a light on that, that we've moved to a point now where we have to face up to dealing with a different problem in healthcare, a changing nature of healthcare needs themselves, a shift towards much greater longevity, and with that, a much greater burden of chronic disease. And so rather than requiring health systems that treat the acute episodic nature, which is still there, the predominant burden of healthcare has shifted over those years towards long-term chronic illness. But unfortunately, very few healthcare systems around the world have themselves changed or shifted to meet that changing burden of disease itself. And coronavirus has really picked that out by focusing in on, unfortunately, some of individuals and citizens in our many jurisdictions who are more susceptible, the older population, those with chronic disease, the vulnerable. Coronavirus has been cruel in that respect. It hasn't been a great leveler that people perhaps spoke about in the very early stages of winter and spring last year. It's been very clear, and the figures show that those who are most vulnerable are most susceptible. And I think that forces us to confront some of the issues that the nature of healthcare that we are so familiar in delivering needs to change to meet the needs of those patients. against that backdrop has been the continuously rising cost of healthcare. I think that is felt particularly acutely in islands for a number of reasons, but nowhere in the world really has been immune to that. And there is a question now to be asked as to the sustainability of many health systems going forward, even well-established ones. And I think one of the points that worries me is that even as coronavirus starts to slip out of some of the headlines in different jurisdictions, as vaccination rates rise and instance of infection falls, and there is a risk that some people, the layperson, will start to think that coronavirus has gone away or at least settled. But I think what many of you and I working in healthcare will realize is that the after effects are going to be here with us for a decade, potentially. I've been involved in some academic research in the UK, just looking at surgery and the potential outcomes. We modelled globally last year the potential for the backlog of surgical cases, looking at the drop in operative rates in different jurisdictions, and looked at what the time was going to be required if we could restore surgical services to normal. How quickly would be able to catch up with that backlog. And we estimated, and this was only really after the first wave last summer, that we were looking at a backlog of at least 3 years, optimistically, if we could restore surgical services to normal. And of course, since then, 12 months have passed, and we've seen many, many more waves and many growing waiting lists. And we're looking at a backlog now of at least 5 to 7 years in jurisdictions that are really able to get back on top of healthcare delivery. And all of that will have an impact. Are we going to, how are we going to restructure the system? How are we going to pay to catch up on that backlog against a backdrop of burning out healthcare staff and a very, very significant change in people's ability to be able to work at the pace they've been working at over the last year and a half. And that really brings us on to some of the workforce problems. We went into this pandemic with a global crisis in the healthcare workforce. The WHO had estimated we were nearly 13 million short of healthcare workers. So we didn't start this pandemic in a good place at all. Now, we have seen in many jurisdictions globally a significant rise in the number of people applying for medical careers, big jumps in the number of people applying for nursing and for medical courses and other allied healthcare professions. And that is perhaps because on one hand, people have seen front and center in daily headlines the real role and value that the healthcare workforce has in fundamentally changing the health of the population. You know, the impact and value has been emphasized 100 times during the pandemic. But also some people may see a certain job safety and security at a time of great uncertainty within other professions that people might have thought about stepping into. But of course, that isn't an immediate fix at all. Typical training in many jurisdictions, if you look at Europe, for example, time to go from entering medical school to qualification, you're looking at least a decade, and some specialties longer. So that is not going to be a quick fix. And we need to protect and look after our current workforce, because really the risk of them leaving, retiring early, could leave a gaping hole. The next point, digital, I'm going to come on to and talk about in a little bit more detail as we work through this. And so I won't touch on that now. Suffice to say that healthcare as a global market sector has been one of the last to come to digital transformation. And I will share with you some of my perspectives. And I think the case is really made now for the fact that digital transformation is arriving for healthcare, and there's a huge opportunity for this, particularly within islands. The wider determinants of health are a cross-cutting theme really across all of this. And I think we acknowledge that in many areas, there are perhaps weaknesses in some of the wider public health messages that need to be get across. It's certainly something we've been talking about in Bermuda, looking at rates of diabetes and obesity, and some of the social factors that come into play with both of those. And I think that is going to be an increasingly recognised and hot topic going forward. And certainly, I think many would agree that is overdue as well. And then finally, touched on the point about multimorbidity, and that unfortunately it has really been a point of section for some of the most serious cases with coronavirus. We have a population that is significantly more multimorbid. People are living longer with many chronic complex conditions, as I say, the nature of healthcare that we need to deliver has changed, and it's important that we recognise that, because that is a trend that is going to continue. So that really sets out where we were before the pandemic even hit. And one of my reflections is the point that an awful lot of learning can be brought out of this. Now, I share this graph regularly, and quite often I make a point of talking about it and reflecting on it. And many people look at this and they see the waves, and everybody knows in a coronavirus talk immediately what I'm talking about. And certainly we've seen many more waves now. But often when I present this slide, I don't reveal the dates on the bottom, because one of the real elements that surprises people is we have been here before, and we have a lot to learn, and a lot of what is still making headlines today, and I was only just critiquing this as I watched the news last night, a lot of that what is making the headlines today are not surprises. If you are a good student of medical history, there are many commonalities from unfortunate historic pandemics. This is actually the Spanish flu, and this is weekly deaths recorded from the boroughs in North London. And it is striking, the number of weekly deaths is far higher than we've seen in many jurisdictions, certainly in isolated London boroughs in London during the pandemic. So it really gives you an idea of the burden of Spanish influenza back then. But some of the general points and learning from this should be well established and should be better known than they are, because, as I say, many of the news headlines shouldn't be surprises. And some of my reflections on this are shared on this slide here. And as I mentioned already, NHS Nightingale, the series of major pop-up 1,000-bedded hospitals that were built in just a matter of weeks across the UK to deal with the overflow. Well, we have been there before with temporary hospitals, not a new initiative, and there's a good picture illustrating that just here, perhaps a different time and a different setting, but we've been in that position before. We've also been in the position of having to recognise the much greater and important central role that governments can play in taking control of emergency planning and providing that comfort and reassurance to make the necessary decisions and interventions. And certainly one point that I think is increasingly recognised now is that in recent decades, many governments have focused on disaster, catastrophe, particularly in Western Europe and United States, thinking about terrorism. But unfortunately, the length of time that had passed since the last major global pandemic, and truly global, not just SARS, for example, but it's interesting to see how much better prepared some Southeast Asian countries were at dealing with the pandemic when it arrived, because they had organizations and governments that were able to react quickly with recent experience, only just nearly 20 years ago, to be able to deliver this. I think other points that really stand out around this are prioritization of population health and public health within that. Perhaps some of those points, the reason that we need to focus in on some of the social determinants of health, health messaging, basic health prevention and promotion, are because in recent years you could make a case that public health has perhaps sadly been a little bit overlooked, more so than it should have been. And many other points come out of this as well, but perhaps the final point I'll touch on, and this links to why I think digital health, that the time is really going to be now, is that if you go back and look at Spanish flu and what happened in the years afterwards, it was, up until perhaps the most recent innovations around biotech and other areas, it was perhaps the point in time when there has been the most accelerated innovation in terms of healthcare. The League of Nations and then subsequently WHO also ultimately stemmed from work following the public health response and global recognition of the need to coordinate and prioritize that at international levels in the 1930s and then into the 1940s. So also at that point of governmental organizations and centralization, coordination and sharing, that was also in a way an accelerated innovation that came out of Spanish influenza all those years ago. So I think there is absolutely no doubt, and it's not making the headline necessarily right now outside of vaccines, but there is no doubt in my mind at all that the prioritization of healthcare and the fundamental shift and acceleration in innovation that has come with this period will continue well into the next decade or 20 years from now. We will still be seeing the positive benefits from the pandemic that we've all faced over the last couple of years. So what are some of the points of global learning that we've really pulled out from our international work? And the top 10 are listed here, and we've actually shared a number of global reports pulling this out, and I will take you through one of the key points from mine on this. But the headline points here, and I will pick out some of these to go through in more detail, in the immediate pandemic points are digital delivery. So the incredibly rapid shift and engagement with digital, which I'll detail more. The recognition of the need for clean and dirty sites. So hospitals that and health centres that deal with the acute contagious disease, and others that try to keep clean of that and try to continue with the business as usual of healthcare as much as they are able. And similarly, hot and cold sites, the sites that deal with the acute emergencies and those that deal with the backlog and the elective cases that still need to be processed and operated on. And in recent decades, and that is a traditional model of healthcare, if you look back 100 years, there are good examples around the world of what used to be called lying in hospitals or fever hospitals that really just dealt with the dirty and the hot cases. And that segregation used to be there. And over the years, we've amalgamated into mega hospitals and mega sites. And actually, there is a strong case for reflecting on that and thinking about how we can learn some of those lessons from the past and work differently. Scaled up primary care, goodness me, the pandemic has really emphasised the need for primary care and the agile ability. It has taken such a heavy weight on its shoulders over the last couple of years, and will continue to do so, I fear, even when coronavirus is out of the headlines, as I say. Aged care services, again, certainly an area you will recognise that a bright light has been shone on during the pandemic. But also perhaps some of the areas behind the scenes that perhaps people don't normally typically think of. And supply chain, the resilience, many of you I'm sure will be familiar with the race at the beginning of the pandemic to ensure that proper PPE equipment was in place and that ventilators were sourced. And this is an area that perhaps hasn't received as much attention as it should have done in healthcare over recent years. And I'll share with you some of the points we've been helping think about that. And that very much links into point 7 as well, which is a way of thinking about better coordination, not just of supply chain, but also of beds and workforce and staff. And we've seen many health systems scale up what we sometimes call air traffic control towers that are able to take that bird's eye radar view of a health system at a moment and be able to indicate where needs are, where capacity is, where workforce is, and make best use of that across a hospital or indeed a whole health system. And we've seen the case for that made in the last 20 months. Agile workforce, I've touched on and we'll talk about more in a moment. Governance is certainly a point. Many systems have been forced and stretched into position to react very rapidly, but within that, some of the processes, regulation, accountability has also had a bright light put on it. And of course, behind every single one of these points is the need for all levels within healthcare to recognise that on one hand, there is a very specific to healthcare, a technical need to understand the nature of the policy, the strategy, the operations. But on the other hand, all of that is fruitless, not pointless, but not realised. The opportunity isn't reached without the knowledge of good project management and implementation skills to be able to put all of this in place. So I'll pick out some of those points. And this is back in spring last year. This was the original framework that I started to develop to help think about what are to sort of simplify and to pull apart some of the key elements that really came out of the huge noise around the pandemic. And I think this really still has utility now to break down all of the noise, all of the headlines into the fundamental points that we need to be focusing on: managing the outbreak, exiting confinement, and finding what the resilient new reality is in healthcare. And that point is really some of the lessons I'll go on to share with you now. And those points underneath are really the focus. The fact that we're at a point now where new care models to address all of these points need to be developed, and the enablers for those are digital delivery, agile workforce, resilient operations, and financial recovery. And I think the fundamental point that I speak of quite regularly, that I think people really need to realize, is that when people want the pandemic to be gone and they want things to go back and be able to get on with their life, I think the fundamental point that we have seen phased throughout different jurisdictions as they've recovered and returned to their business as usual, that fundamentally healthcare is not going to go back to how it was. And nor should it, I think, is the other key point to emphasize as well, because as I mentioned, we were not in a great place before it started. So if I pick apart some of these, and I'll go through each of these individually, digital delivery has great promise for thinking about how we actually think about delivering care differently in the years ahead, but also underpinning that, how we do a better job of managing the resources and capacity that we have. Workforce is very much about focusing on the flexibility, thinking about who does what, and I'll go back into that in more detail in a moment. Next, the care models, and this is well beyond COVID-19, it's about dealing with that longevity, that multimorbidity, dealing with that chronic nature of disease. The operational resilience, thinking about the technical workings of how we deliver healthcare. So not just the technical nature of disease, of diagnostics, of the right treatment, and that frontline perspective from physicians and allied healthcare professionals. This is more thinking about and how do they get what they need to do the job that's in front of them? How do we manage that supply chain? How do we assemble the right resources and ensure there is the capacity in place? And then finally, the financial recovery, the cost of care that are touched on already. There are a number of points to think about in that as well. So I mentioned that I wanted to pick up on digital delivery first, because I think this is perhaps visually what we will see change most in the years to come. And there are a number of lessons to share on this, and I'll pick up a few points. The first is the incredible shift that we've seen from many providers globally during the pandemic, the very quick reach for digital elements of digital healthcare to help them deliver what they needed to be able to continue as best they could. And we've certainly seen that in other areas outside of healthcare, the shift to remote working, the mere fact that I'm able to join you virtually for the conference today. And while that may scale back a little bit in the time to come, and certainly there are big debates and headlines about whether people really will return to offices and to what extent, and I think within healthcare, we will see a little shifting back. But I think the baseline has now changed. My worry in all of that, and an important point to flag, is that when that quick reach was made back in the early days in March, April, May last year, this was done as a bolt-on. And one of the risks with digital healthcare and digital delivery is that without integrating it into current practice, first of all, it simply may not fit, it may not dovetail, it may not comfortably work within existing process and the existing workforce. But secondly, a bolt-on is also easy to bolt off. And there is a greater chance of some of these gains being lost because of the ease of switching on and switching off in that respect. For digital health to be successful, and this is a global lesson to share from around the world, and pre-pandemic as well as during the pandemic, the most successful adoption of the digital elements of healthcare have really been when it is built in to the existing process. It's leveraged. It's a clear value add for what people are doing, but it's not necessarily a whole new way of working, a whole new process. It adds to the points that it's best able to add to within the existing way of working. And so you can see here some of the shift, and similarly in other health systems around the world, we've seen in many areas a 50, 60, 70% shift towards digital ways of working, online consultations, remote monitoring, Absolutely incredible. Now, all of that was ready and waiting to go at the start of the pandemic. It just needed to be adopted. And as I mentioned already, healthcare as a market sector has come very, very late to digital, but its time is now. Three real areas where we're seeing this playing out, and that is the sort of three dimensions of this cube. Who are the population who are able to be engaged in this? Is it individuals with particular diseases or comorbidities, or is it everybody who is looking to potentially access a particular hospital service, for example, everybody who's looking to access their results online, which healthcare institutions engage? And then also, what extent, what elements of the care process? Is it simply an initial online consultation rather than in person, or is it an entire care pathway that's shifted? So there are a number of elements within this, and I think, as you can see here, this is a trend that is going to accelerate very sharply over the coming years. And to emphasize that point, I wanted to share here some of the information from what's happening behind the scenes. There has never been a greater jump in venture capital funding going into digital health last year. And within the first quarter of this calendar year, it has almost been equaled. So that trend is going to sharply rise and continue, because people recognize that the case has been made, and that providers and payers are at a point in the time now where they're looking to get on board with this. So there is very good reason underpinning this as the future direction of travel. And where is that money going? It's currently going into telemedicine, which is perhaps not surprising given the pandemic. Also apps. But some of the other points there, where my personal opinion is that some of the greatest future opportunities lie, perhaps aren't recognised in that breakdown of the funding yet, but will be, I think, because obviously the nature of the pandemic has emphasised the need for telemedicine. Down the line, I think we will see much greater interest in starting to use some of that data and the analytics, promoting wellness much more than we are doing now, and remote monitoring also. And I think the technology and experience in that area will catch up, and we will see that sharply rise in the coming years. So we'll quickly touch on those other points that I mentioned earlier. So agile workforce, and the great example of this is NHS Nightingale, as I mentioned earlier, because it really brought the principle behind this out to play, which is this. If you look at the workforce that we have, and you look at the tasks that they complete and the competences that they have, there is actually not a great alignment between those points. And if you have a limited workforce, you really want to make sure that your highly trained professionals across the breadth of healthcare practice are doing the tasks that they are best trained to do, and that they themselves are best able to do. So I was just talking to a clinic last week in another island, not in Cayman or Bermuda, that will remain nameless, and talking to them about the time that physicians in that clinic spent chasing the repair of their computers and the fixing of their photocopier. That is not a good use of their time and of their medical training. It reduces their capacity to see patients, and it frustrates everyone in the workforce. Now, extend that to NHS Nightingale, and it gave a phenomenal opportunity, given the number of beds that needed to be looked after, and given the very short number of critical care nurses that were available. We atomized those jobs and really looked at the tasks that required only an intensive care nurse to do. And we brought in people to help with everything else. There was the benefit of the army, but also volunteers. Many volunteers came forward to help the NHS, but also administrative staff, receptionists, other people repurposed to make that job spread much more widely and allow them to focus on what needed to be done. Now, that is an acute and particular example, but applying that principle more broadly, it's really important that we look at our workforce and start to ask whether we are making use of them in the best way that we can do, recognizing the shortages that we have. I think the other point that will really come out is highlighted on the bottom here, and the need to think about our own healthcare staff wellness. because the toll of the pandemic has not just been on patients, it really has been on the healthcare workforce on the front line themselves, as well as I'm sure you well know. And we're seeing really interesting initiatives around the world starting to recognise that and help them out. And I'm happy to share some further details around those. New care models, I think both the workforce points and the digital delivery points both come together into that wider point about reflecting care that needs to be given, not the traditional model that we mostly have from many years ago. And what do those models look like? The integration is a word that is thrown around and means many things to many people. But I think fundamentally, the future care model is an integrated care model. We have a time where patients who had an acute episodic condition could be treated by an isolated range of specialists, doctors, allied healthcare professionals, and due to the acute episodic nature of that disease, that isolated treatment touch point worked very well, and it was fine. But if you have a patient with long-term chronic disease who lives with that for decades, and they see a physiotherapist, they see an acute physician, they perhaps occasionally require input from an emergency department, they see seen regularly for diagnostics, they perhaps have the input of nutrition, they perhaps have social needs. Suddenly treating that patient in those different areas in isolated silos fails the patient, fails the system, and ultimately will fail the providers. And integration, to me, really means the ability to move from a provider-centric health system to a much more patient-centric health system. And that is sharing information, sharing needs, sharing data, managing patients to guidelines, sharing our understanding of how we are coming together as a healthcare profession to meet what's required. And only in that way will we shift the curve and move the needle and start to improve population health, because these patients with long-term chronic diseases, unfortunately, really won't get the outcomes that we can deliver and that they deserve by continuing to deliver healthcare in a fragmented, siloed way. And that is a global trajectory. It's accelerated greatly over the last, well, I would say even over the last 5 years, but it's been accelerating over 20 years. And some of the world leading examples of those, for example, Elite Health Services, who deserve to be much better well known in Israel, the Singaporean health system, and some of the leading healthcare providers in the US, particularly Kaiser Permanente, for example, have been delivering this and world leading in this area for decades already. And so there are many places we can share and learn global lessons from. Operational resilience, I've touched on a little already, and this is really where there is the need to bring in the command center, the air traffic control, the bird's eye view of what's happening, either in a healthcare provider, and certainly I've been fortunate to visit some of the command centers of individual hospitals, really leading examples of those in Europe and the US, and see the benefit it brings from having that. But then also from a health system perspective, from a ministry perspective, being able to understand bed state, the supply chain, the workforce, the capacity, and being able to get a regular snapshot. And perhaps in the hospital, that really needs to be an hour by hour perspective on the operational running of the hospital. But from a system perspective, perhaps that's just reviewing an agreed set of metrics every month, initially, to look at how performance is improving and things are being optimally managed. And it's not just for the benefit of patients. This operational resilience is also beneficial to the bottom line of providers. Making best use of the resources that you have in an efficient and productive way is a powerful economic incentive for delivering this way of working. And it's again an area that perhaps healthcare can learn from other market sectors and industries on, because we haven't perhaps been as good at focusing on this area as we could have been. Financial resilience is the final of these points. I think there is nowhere in the world that the coronavirus hasn't really posed a major challenge. And many healthcare systems were having to adopt and adapt to new funding models and new ways of working before the pandemic. So we're really starting to see a much greater focus on this. And you can well imagine, with our background, it's been an area that has been very much in demand of really trying to get a grip and control on current financing, but then very rapidly start to look for opportunities for cost improvement, for insights, for automation, for flexibility, and ensuring the sustainability and in many cases the survivability of both payers and providers. And I think while providers have been on the immediate front line, we will now start to see in the months and years ahead increasing challenges for many of the payers as well, be they national health insurance systems or many others in the private sector as well. So these have kind of come down to the 10 key recommendations that come out of that, and I will very quickly take you through these as we come to an end. And these are really our perspective both on the global learning, but also a bit of future gazing, not just about what's been done and what's worked, but also what needs to be done and what's vital to be done in the years ahead to improve healthcare for patients, providers and payers. Firstly, we must continue the acceleration of digital transformation in healthcare. The opportunity is huge and the time is now, but also building specific solutions to care models, making sure that the care model is redesigned and updated alongside digital, but ensuring that the best of digital is brought into that. That point about bolt-on versus implementation and integration to ensure that it's successful and harnesses all the opportunity that it can. For agile workforce, I mentioned already the focus on tasks and competences. We need to look again at our workforce and understand how we all make the best use of our healthcare colleagues working with us in this area. But we also need to focus on the heavy toll that it's taken, the attrition and burnout, and how we address that. Developing new models of care, as I say, both of those feed into this. We started in a point that we really needed to look again at how we delivered healthcare, and that time is really now. There are so many opportunities for improving how we deliver, and I think the focus on pulling out some of the learning, but also focusing on some of the new opportunities, be that virtual care or otherwise, are going to be vitally important. The points around operational resilience, I think we'll see that shift towards command centres and that type of approach, even if that is perhaps not a bunker or an air traffic control tower, even if that is simply a better process, a better governance, a better accountability, a better measuring, monitoring and managing being put in place, but a greater standardization of that, I think, will come to the fore. But also we will see a much greater collaboration. I think that is going to be an enabler that helps us break out of some of the fragmented silos that we've been working in perhaps for too long in healthcare. We and many have built very good, close, strong relationships through adversity. Previous concerns, be they disagreements or just misunderstandings around different groups within the health system, many of those barriers have been broken down in the pandemic, and this is an opportunity to build on that and take that collaboration forward. And the final points on financial resilience, I just touched on. So touching on some of the points, particularly around payer reimbursement schemes and thinking about how we do a better job of compensating given some of the challenges, but then also some of the more fundamental operational points around financing, the financial recovery, the liquidity, the efficiency and productivity points within that, and importantly, the importance of delivering cost saving at all elements. I think perhaps for too long, and I think this is a point that is particularly true for islands, for many islands across the area, having a look at purchasing and procurement and new ways of approaching that, perhaps consolidation, centralizing that, perhaps even taking a national approach or different providers joining together to collaborate on approaches, offer an opportunity to deliver very, very significant cost savings in that area. And again, I'd be happy to share some of the experience that we've delivered on that. I say that point firmly with the benefit of personal experience for having seen what that can deliver for islands. So the final point, so if you're interested in learning more, then there's a huge amount of learning you can share. Very recently, just shared in the last couple of weeks, some wider, bigger picture points around how COVID-19 is reshaping healthcare. That's a good long read, though I would say so myself, but that touched on some of the bigger points about the possibility of using changes in workforce to become a strong employer and economic driver for islands, for strengthening healthcare workforce, perhaps economically as well, for starting to onshore care, and indeed perhaps take advantages of more established healthcare systems, weaknesses or shortcomings to be able to provide islands providing care for others coming to those islands as for care. So, and finally, perhaps the biggest picture element of this, the ability of the pandemic to drive the case for universal health coverage, which will be a controversial point in many jurisdictions, but you could argue that the case has been made very strongly. Recently wrote an article in the Cayman Compass looking at digital medicine in particular, an area of interest in mine, and very happy to get in touch with anybody to discuss any of this in further detail. And my final point is just to say that's my learning, but there is many more points from my colleagues across the world. These are some of the 12 fundamental trends that we've mapped in healthcare. These are some of our recent reports touching on everything from workforce and integration to specifically primary care, digital health, and thinking about lean and operational excellence approaches to create a culture of excellence in healthcare. And be very happy to go into more detail with any of these or share any of these reports and publications to help stimulate everybody's thinking, share some of our learning, and perhaps explain a few good ideas that others are thinking in this area. So thank you very much. I'll finish there, but also very happy to connect anyone with any others in our global network across the islands as well. But thank you very much for your time and listening. Really pleased to join you today and happy to take any questions.
Okay, Dr. Fitzgerald, thanks for that presentation. We'll open it up to questions from the room if there's any who have. I see a few questions here, but I'll ask one that has come in from somebody who's been viewing online. Does KPMG Worldwide have a mandatory vaccine policy for employees? And if so, what percentage of employees are currently vaccinated, and have any been let go for not getting vaccinated?
It's a great question. So not yet, but it's certainly a hot topic, and it will be interesting to follow that very closely. And I should say the nature of KPMG globally is that it will be individual firms in individual companies that will make that decision rather than a global policy. But certainly we're already starting to see that being discussed, and it will certainly be an interesting one to follow.
Okay, we will move to the room. We have a question for you.
Morning, Ed. It's Ollie Kays. I'm formerly of Leeds, UK. I'm now of Doctors Hospital Cayman. Fantastic talk, and I've been tracking the website for the last 6 months and seeing these sort of targeted approaches you're putting in place. From your perspective for a small island, and particularly working its way down to the smaller units and then the individual within that healthcare system, your presentation is top down. What do you think about the bottom up perspective?
Great question, and I should say apologies if there's any difficulty with the sound here. We have a torrential rainstorm outside in Bermuda, so apologies if that's interrupting. So bottom-up learning, yeah, I think you're absolutely right. I think this actually plays into that point around operational excellence. So as someone who spent over a decade on the front line, this is a personal bugbear of mine, that often the people who know the answers best in a healthcare system are those people that are solving the everyday problem on the cold face. And while there is an important top-down element of providing that big picture shaping, there is a tremendous need in healthcare to actually empower and really strengthen the voice of those on the front line to be able to share that bottom-up learning better. And there are other industries outside of healthcare that have been able to do that well. unfortunately, I think
let's hope this is temporary. We'll give it another second or two to see if we get Dr. Fitzgerald back with us, but we've all dealt with this over the past year and a half, how many meetings we've had that have gone this way. And we wait to see if we have Dr. Fitzgerald able to come back. But it appears as though we've lost him for the moment, but what we can do is we can collect your questions. You can go to the Healthcare Conference social media platforms, submit your questions there, and we'll do our best to get those answered as well. So we're going to be getting set for our next presentation, and we'd really like to thank Dr. Fitzgerald. Technology does what it does, so we won't hold that against him, and hopefully we'll have him able to join us at another event in person. But I think we're going to quickly pivot and move to our next presentation. If we are, we will go to a speaker from our sponsor, Infinite Mind Care, Raquel Tobian. Raquel is a clinical social worker and a chemical dependency counselor at Infinite Mind Care, and she'll be presenting today on suffocating from stigma, something that I think we all have an interest in listening to. Let's welcome Raquel.
Is this how I advance slides? Thank you. And I'm gonna set that there. Hi, everyone. I'm Raquel Tobian. As he said, I'm a social worker and licensed chemical dependency counselor at Infinite Mind Care. I want to thank you guys for being here today on this Saturday morning with me. I'm really glad to be here, and I'm very excited to speak on this particular topic. Addressing mental health stigma is something that I think is so critical and important. I know from my own experience that when we help even one person seek treatment, we end up actually helping not just that one person, but we impact their spouse, their children, their family, their employers, and ultimately we're impacting the community as a whole. So when we address stigma and helping folks feel comfortable coming forward and getting the help that they need, it has an incredible ripple effect to everything that we're seeing in our communities. So what are we going to be talking about today? I want to go over what I would call a very ambitious outline for our presentation today. We're going to start off by understanding implicit and explicit bias and talking about those. We're also going to be looking at our own personal bias around mental health and substance use disorders. From there, we're going to talk a bit about how bias translates into microaggressions, which are our behavioral actions that actually contribute and lead to the stigma that we have around mental health and substance use disorders. We'll also talk about why stigma actually matters. Why does it matter that these conditions are stigmatized, and how does that cause problems for all of us? We're also going to look at how we can make changes to that. What's our personal responsibility? What can we do as individuals? And how can we become an ally against fighting stigma in our communities? So I like to start by saying I don't have all the answers, which is maybe not a great thing to do when you're an expert speaker, but we're talking about a difficult topic and a really complicated topic. Bias and stigma are multifaceted problems. So I start off by saying I don't know all the answers. I don't get this right every single time. None of us are free from making these mistakes. And when we're talking about something that's difficult, I want all of us to show up and release that perfectionism, right? Show up with this idea that it's okay to not have all the answers. It's okay to not get it right every time. But I can be open-minded, and I can sit with the fact that sometimes talking about this can be uncomfortable. That being said, I would also ask that when we get to questions, if anyone has them, speak from your own experience when we're asking those questions, and be open-minded and share that space. So, getting started with examining our bias. When we look at this slide, I want to read a couple of these things, and I want you to check in with yourself if maybe you've ever had thoughts like this about someone in your life. Maybe you've thought, depression? I think they're just lazy. Or someone using substances. They're never going to stop using, they just don't care. Or when you see that rowdy kid, ugh, ADHD, that's just bad parenting. So let's talk about that a little bit more. When we're talking about bias, there's two types of bias. We have implicit bias and explicit bias. Explicit bias is the bias that we all know about. It's on display, right? It's generally, we're also aware of it for ourselves. It's the things like hate speech, discrimination, prejudice. We see it, we all agree on it. It's things like the manager who says, ugh, those millennials, right? There's a clear bias there and no one's hiding it. It's out there, it's public. Implicit bias, on the other hand, tends to be unseen and invisible. It might be that gut reaction we have, maybe to some of those statements that I read on the earlier slide, and you went, yeah, I've thought that, or I've had a similar thought about someone in my life. But it's not really always in our conscious awareness. Sometimes it's below the surface. Sometimes we're not aware of it at all. You might, for example, say and believe men and women are equally good at math. But below that belief is potentially the understanding that there is some bias there, and you actually associate men with math more than women, and you're more likely to engage around that belief. I also want to point out, and I think I've already said this, but none of us are free from having bias. Even the folks that are meant to be impartial, like judges, they still have implicit bias. And some of our implicit bias is extremely pervasive. For example, in-group bias might be something that you've heard of. We have a natural tendency to identify and prefer members of our own group. So what does that mean? A group can be defined in a lot of ways. That might be our race, it might be our gender, it might even be our age, it might be our nationality. It can even be things as kind of silly as what school we went to or the sports team that we root for. Obviously, if we're arguing about our sports teams, maybe that's less of a problem than when we're preferring different groups for some of these different reasons. The other thing about implicit bias is that it doesn't necessarily even align with what we would say that we believe. I might say, no, I'm entirely unbiased. I don't have any concerns about someone who's in recovery from a substance use disorder. As a professional who works with them, I'd like to think that that is truly what I believe. And yet our implicit bias, because it's underneath our own awareness, we often don't necessarily have that conscious clarity that we do have bias, right? And so sometimes our bias doesn't align with our personal belief system. I also want to say that the good thing about bias is we know that we can actually change it. It's malleable. With work, with some effort, those biases that maybe we've learned or developed or just innately have are actually able to be changed. I want to take a minute and examine some of our own biases. I'm going to ask you to recall some of the earliest messages that you might have heard about mental health or substance use, whether positive, negative, or neutral. And just kind of take a minute and think about that for yourself. What were you taught in your upbringing about what it means to have a mental health condition? about what it means to have a substance use disorder. And when we were all going to be in person for this, I had a really nice handout that I planned to have available for you. But because a lot of this is being streamed, I'm going to read a couple of these questions. This is a personal assessment of your own bias. And this handout is available for anyone who would like it. If you go on your phone, you can actually pull it up really easily. It's bit.ly/suffocating from stigma, and it'll pull up the full handout for today's presentation. But since this is being streamed and we may not all have access to our phones, I'm going to read a couple of these bias questions. And as I do, I want you to take that minute to release yourself from that perfectionism, release yourself from the idea that we don't have bias, and I want you to just notice what reaction arises for you as I ask these questions. How do you react to learning that someone who smoked cigarettes or used tobacco products all their life has been diagnosed with lung, mouth, or throat cancer? Are there any jobs, positions, or professions that you think individuals with mental health disorders should be barred from holding or entering? If yes, why is that? What about folks in recovery from a substance use disorder? Are there any jobs and professions that they should be barred from entering? Would you go to a physician or therapist whom you knew or believed to be in recovery from a substance use disorder? What about if you knew or believed them to be taking medication for their own mental health? Have you ever used terms like crazy, nutter, nut job, mental, nuts, psycho, spaz, loony, lunatic, demented, deranged, mad, fruitcake, either to describe an individual with a mental health condition or to make fun of someone without one? When you look at those questions and you think about your personal response to them, I know we have a relatively small room, but I want to ask you to show up with some vulnerability. And I'm going to ask if you had a reaction to any of those questions that makes you a little bit uncomfortable, or maybe you would be not wanting to admit it publicly what you thought when I asked them. If you can raise your hand and maybe recognize some of your own bias. Thank you. I bring this up in part because recognizing our own bias is our first step in being able to address the stigma that comes with our mental health disorders and substance use disorders and ability to seek treatment. Statistically, 1 in 5 of us, even in this room, has a mental health condition. Take a look around. Even outside of this room and in our own lives, take 5 people that you know and realize that in each group, statistically, there's one person in that group struggling. Maybe more. I hear some people laughing a little bit. Out of 5, we're like, oh, yeah, I can think of a few more. So I want to talk a little bit about microaggressions and how this relates to both our bias and translates into creating stigma. So microaggression theory, how many of you have heard of this? Okay, a couple of people, but not many. Microaggressions are brief and commonplace. They're verbal, behavioral, or environmental indignities that communicate hostile, derogatory, or negative slights and insults towards marginalized groups. And marginalized groups, this is by no means an exhaustive list, but here are a few of them. It can be women, it can be LGBTQ folks, it can be folks with mental health or substance use disorders, racial and ethnic minorities, disabilities, the elderly, the poor. Any marginalized community or group can be a target for microaggressions. And microaggressions can be intentional or unintentional, but often the people that perpetrate a microaggression are actually unaware that they're doing it. They engage in this in a casual way, and they don't recognize some of the harm that it can cause. And we're going to talk a little bit more about what exactly microaggressions are, but I also want to mention, since many folks are not familiar with microaggression theory, that this was developed by Dr. Chester Pierce in the 70s. Microaggression research and theory originated looking at the experience of being Black in America and how subtle and often automatic nonverbal exchanges impacted put-downs towards Black people in America. Now, microaggression theory has expanded to look at how that can impact a variety of marginalized populations. And specifically today, we're focusing on microaggressions related to mental health and substance use. That being said, I also want to recognize for a minute the impact of intersectionality. So again, initially this experience or research on microaggressions started about being Black in America. Since it has evolved, though, we've been able to look at the various microaggressions that are impacted on the wide variety of sort of identities that we may hold. That can be things like being both a female, maybe a lesbian female with a mental health consideration or disorder. All of that is going to impact the experience of microaggressions in society. And generally, the more intersecting identities that we have, the greater the experience of microaggressions that someone is having. I also think it's relevant to say and acknowledge my own status and privilege speaking on this topic. I stand here as a white, able-bodied, educated, cisgender female. I'm not immune from perpetrating microaggressions, and I'm not immune from receiving them. I also want to recognize, since we're talking about mental health and substance use disorders, my own privilege of standing here and being recognized as someone who many people perceive as not having any mental health or substance use concerns. And I pause for a moment so that you can look at whatever reaction you might have had to that statement. You might have had the thought, wait, does she have mental health or substance use concerns? And then you might have thought to yourself, another thought, another bias might have come up. And I ask you to look at that. Why does that matter? Does that make what I'm saying less valid? Does it make it less believable or less relevant or important? So checking in on that, checking in on your own experience of that. So let's talk a little bit about what microaggressions are. Microaggressions have been kind of categorized into three subforms: micro-insults, which are often unconscious, micro-invalidations, which are also often unconscious, and micro-assault. Now, I'm going to start with talking about micro-assault because these are the things that are actually conscious. They're that explicit bias that we've talked about. It's out there, it's seen. Micro-assault, nobody's trying to hide their bias. It might be something, when we're talking about mental health, maybe someone saying, just let them die. Why are we wasting our money treating them? That's an unfortunate thing that I have heard many times when talking about individuals who struggle with substance use disorders. We might hear people say things like, they just don't care, they're not trying. Or they deserve lung cancer because they smoked for all those years. Those are micro-assaults on mental health and substance use disorders, right? They're just full on out there, they're not hidden, they're discriminatory. The other two types of microaggressions that we talk about are a little bit more challenging because they fall into that implicit bias category. They're the things that we're unaware of. A micro insult, for example, is a behavioral or verbal remark or comment that might convey rudeness or insensitivity towards a person's status. If we're thinking about folks with substance use disorders in recovery, have you ever heard someone say when you're out, "Oh, surely you don't have to keep going to meetings after all this time," or "one drink won't kill you"? We say those things and we diminish what it means for someone to be in recovery. That's a micro insult. And because it's that implicit bias, often the person who says that doesn't even have good awareness of the impact that that has on the individual who's struggling. It might be someone saying, "Do you really need to take your medication?" for someone with a mental health condition. Micro invalidation, again, is often unconscious, and it's verbal comments and behaviors that exclude, negate, or nullify the individual's thoughts, feelings, or experienced reality. That might be the reality of seeing things in our media like alcohol use and drug use being highly glamorized or accepted. It also might be seeing things like mental health conditions highly stigmatized in our media, right? The pervasive view that we portray certain mental health disorders as dangerous. Those are micro invalidations. And again, they're often unconscious, which is part of what makes them really difficult to address and identify. On top of all of this, we're also looking at our environmental microaggressions and how those impact us. How does that show up in our society, right? What are the ways that our society is telling us that there's stigma around certain things? One example of this when we're talking about gender is looking around at your community as a woman and seeing that all of the buildings are named after men. If you've been on a college campus and you're like, "Oh, that's this building and it's named after a man," and you look around and there are no buildings named after women. That's part of microaggressions around gender. Microaggressions in society also exist pervasively around substance use and mental health. Some of the defining characteristics when we're talking about microaggressions is the invisibility. We don't see them. They're viewed as being not that problematic, as being minimally harmful. There's also a catch-22 with responding to them. It puts us between a rock and a hard place. If we don't address it, it causes psychological harm to us. But if we say something about it and we say, "Hey, that thing you said, it was kind of discriminatory or a little bit offensive," we're very likely to have a response with another microaggression. And the person goes, "No, it's not." And you're like, "Well, but it was for me," right? It diminishes that person's reality when we say, "That's not really offensive. I don't know what you're talking about. That's not real," right? It goes back into this idea that this is an invisible problem. The thing is even if it's an invisible problem, it has real impacts. The impacts of microaggressions are significant. These are a few outcomes from research studies that we've looked at when people experience prolonged microaggressions, which anyone who is in a minority group is going to experience prolonged microaggressions because they just don't stop. We can't just magically change our gender, our race, or our mental health or substance use status. And it leads to things like anxiety, anger, stress, depression, lowered self-esteem, substance use problems, and critically, decreased help-seeking behavior. when we're stigmatizing these conditions, folks are actually less likely to come to us and get help. So I want to shift gears a bit and talk about stigma and how these microaggressions that are perpetrated lead to the stigma that we see in society. So this is a saying that I would imagine most of us are familiar with. Sticks and stones may break my bones, and how does it end? Words may never hurt me. I absolutely, more than anything, hate that we teach this saying. Because I would argue that words can do permanent damage. It's a cute little saying that we were all probably taught as children, and hopefully we're undoing it with our current generation, because the reality of our words is that they matter. And we'll talk about why. So first, what is stigma? Stigma is the perception that a certain attribute makes a person unacceptably different from others. It leads to prejudice and discrimination against them. And when we're talking about various conditions and what makes a condition stigmatized, if we think that someone is at fault for their own condition or that they have a high degree of control over it, we're more likely to consider it stigmatized and blame them for it. Substance use disorders fall very heavily in that category. We say it was a choice, right? It's their own fault, they chose to use. Many mental health conditions are also highly stigmatized, and we blame people for them. It's those biases where it's like, maybe I believe depression is real, but when I see it, I go, they're just lazy, right? Again, I believe depression is real. That's my stated belief, but I have the implicit bias that shows up and leads to me still stigmatizing that condition. Destigmatized conditions, when we believe someone is not at fault for them or it was outside of their control. These are things that we see with genetic disorders, right? No one gets blamed for having a genetic disorder. Usually, people don't get blamed for cancer. The exception is the impact of smoking and tobacco when we blame people for their cancer. So, stigma, how does it affect us? I'm going to talk about one study here, and I want to highlight the fact that this is only one study, but there are many, many studies with similar results about why this is really important. So this particular study focuses on recovery and substance use disorders. And in this study, they surveyed 314 individuals, and they asked them about two different groups. And it was exactly the same. The only thing they changed was how they talked about these two groups. And one group was referred to as a substance abuser. And in the other group, they read about a person as having a substance use disorder. That was the only difference in the information that the participants received. And then they were asked about their thoughts and feelings on things like treatment, punishment, whether or not the person was a social threat, that the stigma piece, did we blame them or exonerate them for their condition? And self-regulation, would they be able to address this condition without professional help? Here's what we found. Substance abusers, the folks in the study who read that vignette said that they were more likely to need punishment. They were socially threatening. They were blamed for their substance use related difficulties. And they thought that they should be able to address this condition without receiving any additional help. When we shifted it to them having a vignette about a person having a substance use disorder, they were statistically significantly more likely to say that that person would benefit from treatment. They weren't a social threat. They had an innate dysfunction that they didn't have control over, and they needed treatment help. I want to let that sink in for a minute because this is hugely significant when we're talking about how much our language matters in reducing stigma. The only thing that was different was substance abuser versus person having a substance use disorder. And that was enough to destigmatize people's perception of that individual. Why do I think that is? Why does the study think that is? In part because the term abuse is an extremely morally condemning term. Substance abuse, right? And that's a term that's pretty widely used, substance abuse. And yet abuse, when we think of it outside of that context, we actually use that to describe things like violence, rape, or child molestation. And I don't think most of us would say that substance use is on the same level as those other items. The history of the word abuse also originates from being an extremely shameful practice, a violation of human decency. So when we pair that with a disorder that we know is extremely multifaceted, has genetic components, has biological pieces, has socio-cultural pieces, we're stigmatizing substance use disorders. Again, I'm only talking about one study today, but there are many studies that replicate the importance of the language that we choose to use and how this impacts not just substance use, but all mental health disorders. I also want to point out that probably all of us have had someone in our life who has gone, ugh, everyone is so PC these days. I can't say anything anymore. Do we all know those people? I've heard it. It happens. Some of those people I love. But this is why everyone is so PC these days, because we're starting to understand that the language we use to talk about these things, it's not just language. It has real concrete impacts on people's ability to seek treatment and get the help that they need and recover. Since I'm talking about substance use, and I know I've said this, but these are among the most stigmatized conditions around the world. People often don't want to work with, be related to, or even seen in public with someone with a substance use disorder. And many, many people believe that if someone is suffering from a substance use disorder, that they should be denied housing, employment, social services, and healthcare. This becomes especially problematic when we talk about how healthcare providers treat patients with substance use disorders differently. Clinicians actually have lower expectations for them. There's a belief that individuals with substance use disorders can't change. That's a healthcare bias that we see, and that actually leads to poorer health outcomes for individuals with substance use disorders. I want to talk a bit too about the relationship of mental health and tobacco. So folks with mental health concerns or other substance use concerns have rates of smoking that are significantly higher than the general public. Research consistently verifies this finding. People with mental health conditions smoke at double the rate of the general public. That is incredibly significant. And what is also really interesting is that mental health providers often don't prioritize tobacco cessation as a relevant thing to focus on. And I want to read this because I think it is so critical. In terms of the lives saved, the quality of life, and cost efficacy, treating smoking is considered one of the most important activities that a clinician can do. So what are those biases that show up as mental health care providers and also healthcare providers around tobacco use? Oftentimes, we believe individuals with mental illness are simply not motivated to stop using. We're like, they just don't really want to quit smoking. We also believe that tobacco use is a way of controlling those symptoms. And so we say, oh, it's okay, it's part of what helps them stay stable. We believe if they are gonna quit, it's actually gonna make them worse. They'll have a relapse if they quit smoking, right? Or they'll have an acute episode. Tobacco use is an individual right. That way I don't have to treat it. Also, in inpatient units, a really common belief is that cigarettes are an effective reward system for patients. But that's actually not accurate. 70% of those with mental health disorders actually want to quit. But because our providers believe that they can't, and we hold these biases, we're impacting their ability to recover. So the stigma around mental health and substance use. Why does this really matter? When these conditions are stigmatized, folks are actually a lot less likely to seek treatment. There's a fear of judgment, there's a fear of discrimination, and when the conditions are stigmatized, people are more likely to drop out of treatment or get inappropriate medical care. There's a long-standing shaming around seeking care for substance use and mental health disorders. Society views this as a moral issue, a personal failure of sorts, instead of viewing this as a public health crisis that it is. 60% of adults and 2/3 of children that have mental health conditions do not receive or even seek treatment. 60% of adults and 66% of children. They just don't get treatment. So what can we do about this? I want to go through some options that we have. One of the things I'm going to start with is talking about the way that we can change our language. We have a personal responsibility to change the way that we talk about these issues. I went through one study today about why this is important, but there are countless others. The way that we speak about mental health and substance use disorders impacts the way that people feel about their ability to seek treatment. It reduces the stigma. Another key piece, normalizing treatment. Know what treatment is available in your communities. Speak to loved ones about treatment. Say, hey guys, it's okay, this is a thing we can do. Share your own experience. If you've sought treatment before, talk about that. Normalize that we all need some extra support sometimes. Because again, remember that at any given time, 1 out of 5 of us is walking around with an active mental health concern. The other thing you can do is monitor your own bias and become an ally against fighting the stigma of mental health and substance use disorders. So I'm not sure how well you guys can see this. It looks a little bit fuzzy to me. So I just want to read some of these things when we're talking about bias. Maybe you've called someone attention-seeking before for their behavior. I hear this a lot when folks might express that they're feeling suicidal and someone goes, I think they're just seeking attention. I think they just need attention. They may, in fact, need attention. They're feeling pretty bad if they're saying that. And they're not just attention-seeking, right? They need services. But we say things to folk like, you're so sensitive, or, oh, they're unstable. They seem a little disturbed. Stop making excuses, right? Just do it. We've all maybe thought those things about different folks in our life, and maybe we've said them out loud. So let's talk about why we need to change that and how we can change our language. One of the things you're going to consistently see on here is person-first language. I imagine that many folks are familiar with that, but in case you're not, I'll explain a bit about it. Often and historically, we've referred to people as their disorder. Oh, they're a smoker. They're an alcoholic. They're schizophrenic, right? We refer to that person as just, they are a disorder, instead of using, they are a person who smokes. They are a person who has a substance use problem. They are a person who is struggling with schizophrenia, right? Because they are actually a person first. They're not defined by their disorder. And we find that when we use person-first language, it reduces some of the stigma around people seeking this treatment, and it leads to improved treatment outcomes. As healthcare providers, it's also a really good reminder that all of our patients are in fact people first, that their disorder is often not something that they chose. So for smoker, you might use a person who smokes or a person with a tobacco use disorder. When we talk about folks being unmotivated or resistant, right? Well, maybe they just haven't begun, they've opted not to, they're experiencing ambivalence around making the change that we've recommended or asked them to do. They're in denial. That's one we hear a lot around substance use. But instead using terms like they're pre-contemplative, right? They're not actually aware of this problem yet. They're in a different stage of making changes. Non-compliant is a big one across all medical fields. How many of us have seen that in a medical record? The patient is non-compliant with their treatment. Yep. They may just not be in agreement with their treatment, or they might be struggling to make the effective changes, right? Just because someone is not following through with a recommendation, it doesn't mean that they don't want to. And when we use terms like non-compliant, we find that that increases stigma. It leads to providers feeling a particular way about that patient. Other stigmatized language that we see around mental health and substance use. Certainly, all of the pejorative terms that we use to describe folks struggling with mental health or substance use disorders. I named some of them when we were looking at our own biases. I didn't go through some of the terms that I hear for substance use, but addict, junkie, crackhead, those are things I hear all the time. How many times have you heard someone in your life go, oh, that person's such a crackhead? Bearing in mind that person is in fact not using any substances, but we use it as a way of demeaning someone, right? We use it in an offensive way, and that further stigmatizes someone who is struggling with that condition. Even things when we're talking about substance use and mental health, we also see a lot of folks that are involved in our criminal justice system, and we talk about them as criminals, right? Or felons, or convicts, or offenders, as opposed to person first. They're a person involved in our justice system. They're a person charged with X, Y, and Z, or incarcerated for this. Those things matter when we're destigmatizing and helping people have a desire to seek the care that they need. Some of the other language around mental health and substance use. All right, this is a big one for me. Clean and dirty when we describe urine drug screen results. Oh, it kills me. Please, if you work in a substance use facility or a medical facility that describes a patient as dirty, take this back and talk about why that is so highly stigmatizing. Imagine for a minute, regardless of your status of mental health or substance use, whatever condition you're struggling with, that your doctor describes you as dirty when you come in struggling. Would you ever want to go back and see that person again? I wouldn't. These are some other examples all of the language examples are also available on the handout. There are also some copies out on our table of the handout, and like I said, I'll repeat the link at the end if you'd like to download it. I'll also add that my focus today around stigma has strictly been on mental health and substance use. This is certainly not a comprehensive list of all of the problematic language that we have. And this is by no means a comprehensive list of the way that we can change our language around the wide variety of minority groups and populations that we serve. So I'm encouraging you to take this as scratching the surface on this issue and getting out, doing more research, and looking at what are the ways that I can help destigmatize any of the conditions or populations that I'm serving. Knowing what treatment is out there and available. This is, again, not a comprehensive list. I am very new to this island, so this is what my Google search yielded me. But I believe there are some other tables out there to take resources from as well. But know where to get help if you see someone struggling. Say, oh, hey, you know what? I've heard of this place. We can go there. Or maybe I know someone who's been to the wellness center, or I know someone who's got services at Infinite Mind Care and they really liked it. Here's where you can go. I also want to mention, because the theme is Breathe Easier, and we talked about how underserved tobacco users are. Oh, I just biased tobacco users. I don't know if you guys caught that. When I said at the beginning, I'm not free from this, people who use tobacco, I just referred to them in a biased way. So folks that use tobacco, because they are very underserved and they tend to be ignored by mental health providers because of the bias associated with it, knowing that there is specific and helpful treatment, right? There is nicotine replacement treatment options. There are other medications that can be really helpful. There's also hypnotherapy and behavioral therapy available to treat tobacco use. So how do we implement these changes? Again, showing up with open-mindedness and personal humility around these issues. If you say something that is biased or stigmatized and someone tells you, hey, that thing you said, it actually creates stigma and it's a biased statement. Say like, oh, thanks for letting me know, right? I'll also say policing ourselves around it. We're not perfect. Even speaking on this issue, do I sometimes fall into language like I did here today that I know can be contributing to the stigma? Yep, it happens. That's okay. Personal humility. That's part of keeping ourselves accountable. Working with interdisciplinary and diverse teams in our workplaces and encouraging that, but also in our personal lives. That's part of reducing our feelings of bias towards any group. Make the invisible, those microaggressions, make them visible. Don't be afraid to have conversations and talk about these things. If you hear a colleague say something that adds to the stigma of a condition, call it out, professionally and politely, right? But make it public. That's how we're an ally around these issues. And I think that is all I have for you guys today.
Thank you very much, Raquel. We do have time to open up to the room for questions, but you have captivated people listening and viewing online, so I have a few questions. One, as a parent, what signs can I look for to know if my teenager has a substance use problem?
That is a tough one because teenagers go through some pretty significant behavioral changes. But anytime you're seeing a major change in your child's behavior, I think it's worthwhile to have a conversation. If they're normally very social and outgoing and suddenly you're seeing they're pretty withdrawn, it might be substances, it might be depression, right? It might be another mental health concern. But if we're seeing radical changes in behavior, those are things that we should say, let's have a conversation about what's actually going on.
Is there anyone in the room who has a question? If not, I can go back to my questions. So we have a gentleman over here with a question, and while we wait for him, I'll ask you another one. Do you see the need for an inpatient facility here in Cayman for mental health and substance use for teens, particularly teens, to avoid them mixing with adults?
Well, I think there is certainly a need. Like I did say, I am new to this island, so I'm just kind of getting my bearings. But having worked in residential care in the past, granted I did work with adults, but it's a part of our care spectrum, right? Outpatient services are wonderful, and sometimes we need inpatient care. So certainly I think it's critical that it's available. And yeah, developmentally, I would say that adolescents and teenagers are incredibly different from adults in terms of what they're going through and what they're experiencing. So having separate treatment programs for them would be advised.
Let's take a question from somebody who's in person in the room.
Okay, Andrew Vincent from Integra. Thank you very much. Raised an awful lot of questions for me. One of them was that we often use terms in healthcare very practically, and I'm going to talk about hot and cold sites, and particularly through the pandemic, clean and dirty. That's been really, really common. And it's an irony, of course, because the dirty side is often far more cleaned than the clean side, because obviously we're associating with it the need to protect people within that side. But do you think those things also help perpetuate some of these biases in terms of the way that we look at things when we're talking about clean and dirty? Because, you know, they're terms perceived very, very differently.
So are you referencing like the use of the term clean and dirty when talking about, say, like medical equipment, medical facilities, or
So what we
people?
would typically do, you know, if we were, so at the moment, obviously, where we have COVID within our community, many health facilities are streaming patients into different sections of their building, and they'll often refer to them as, you know, a clean site or dirty site. And so we use it very practically to, you know, to think about how we best stream people and how we protect people. But at the same time, you know, there is an inherent bias with how you would look at those terms. And I, you know, we're using them practically, but I wonder if it's also helping to perpetuate some of the biases we see in other areas, for instance, like mental health.
I would absolutely say yes. If we're referring to like the clean wing and the dirty wing of the hospital, no one wants to be in the dirty area of a hospital. And even though, yeah, it is that practical, like it's just to denote, here's the folks that, you know, have X, Y, Z, these folks don't, right? But that is also extremely biased. And yeah, I mean, would you want to be in the dirty part of a hospital?
No, I think we've got to start rethinking. Actually, that's my afternoon's work, is to rethink how we name these now, so that actually they are very, very neutral. So.
Yeah, rethinking that word, because I certainly wouldn't want to be a patient being served in the dirty area of the hospital. Good call. Don't tell the patients that. But also as providers, how does that make us look at the patients that are in the dirty area of our, you know, facility? Even if we're like, yeah, explicitly, I would tell you that has nothing to do with the patients, that term has a negative connotation. So is there something we, you know, can change that language around that is less stigmatizing?
We do have room for at least another question in the room. So we have 2 questions here, and then I will ask a follow-up on one of the ones I had earlier. Gentlemen?
So I will extend the previous question. So we see patients who have alcohol use disorder who have killed someone in a car accident. Okay. I consider that abuse according to the definition that you have. Then there are those that are admitted alcoholics, that is, they've gone to AA and they have said, I'm a recovering alcoholic. That person, in my specific note, is going to be referred to as an alcoholic, just like the one before is not going to say alcohol substance use disorder. And I like the fact that through this talk, you didn't actually say what substance.
I did not say what substance, and that was specific. So that's an interesting question, and alcoholic, what I usually say is if the patient is choosing to identify with that, and that is part of their own identity and a chosen way of being spoken about, then it's appropriate to also use that. That being said, I've worked with patients where self-identifying as an alcoholic or even an addict, I also have worked with a patient who lovingly referred to himself as a crackhead, and that was his chosen vernacular. And it was empowering to take that label on, right? That was an empowering label. It was a reminder for them of their recovery. I've also seen it go the other way, where taking that label on keeps someone very stuck in their disorder and keeps them from feeling like they're more than that disorder. So in those instances, definitely patient-specific.
Okay, I think there's another question in the room. As we get to that one, to follow up on the question I had earlier, with us not having an inpatient facility here, is there a specific referral system that is used that insurance would cover for off-island facilities, say in the US or Canada?
I am going to fully disclose that I have no idea what the answer to that question is. I will be happy to consult with my boss and get an answer to it.
I think there's someone who could answer that question and who's indicating that they may be willing to assist us with some knowledge there, since that was a question that came in from someone viewing online.
Okay, I'm Shannon Seymour from the Wellness Center. That was a great presentation and lots to think about. There are lots of opportunities for referrals to overseas inpatient facilities in other jurisdictions, and I would recommend that a parent speak with their medical provider and perhaps their mental health provider or whoever else might be involved working with their adolescent. And as it relates to what kind of things we can look for as parents, I think finding evidence of substance use in our children's backpacks or in their bedrooms or in the back of the car that they borrowed, and I think they'll often say that that was their friends or that wasn't theirs. And so I think just being open, having conversations, and keeping that communication going.
Thank you.
Thank you very much. We have a question here, and we may have room for one question after that if there's interest in the room for one more.
Thank you very much. It looks like we have 15 minutes. We can do more than that, man. But anyway, thank you, Ms. Tobian. That was a great presentation. And the previous presentation, I became very skeptic because he went from talking about provider-centric to patient-centric, and then spoke about medical care being an economic driver. And I'm like, okay, how do you balance the two? And then, mind you, that was made by KPMG, right? So I'm like, okay, I'm still trying to figure that out. But even based on some of the things that came up the previous days, I'm off, because when you made mention of the attitudinal behaviors from health practitioners and so forth, I have this question as it relates to whether we have a bigger issue as it relates to a healthcare systemic discrimination as it relates to policies and practices that may be a disadvantage to people who need care as it relates to mental health, but have a problem accessing that care, whether it be because of the type of insurance that they have and the lack of access that they may have. So, because you made mention of persons not getting treatment, and I think it was 60% you said in terms of adults and 65 where children, young people is concerned. How could we minimize that? Does that mean that we have to assess, the access to mental health care? Does there need to be some changes where insurance is concerned or access to? I know it's probably a big question for you, but I would love to hear what you have to say about that.
Yeah, that is a huge question, because part of changing the way that people access care, yes, it is reducing the stigma that exists around seeking care for these conditions, but you're also 100% correct. Even if I want to seek care, if my insurance company doesn't cover it, or I simply don't have access to a provider for those services, how can I do it? So I think you bring up an extremely valid point when we're talking about there's 60% of adults that just don't seek treatment. It's not strictly because of stigma, right? Stigma is part of it, but there's a multifaceted issues that come up when we talk about our healthcare system, and I don't have any easy answers for that.
Another question in the room?
I have a comment, first of all, then a question. Thank you for a great presentation. I think it's important that we actually acknowledge and keep ourselves in check, as you said, because having grown up in Cayman and in the Caribbean, I think a lot of our language, it's cultural. And you're not necessarily aware that what you're saying is stigmatizing because you hear your parents saying it, you hear your auntie saying it, your grandparents, and they don't necessarily mean to offend anyone. They don't consider it a microaggression, or whatever. But it is, I think it's embedded in Caribbean culture sometimes. Even now with my own patients, I'll ask if they have a family history of, mental health illness, and they laugh. That's the initial, no, I don't have any, no crazy people in my family. And they don't mean to offend anyone. They actually don't see anything wrong with what they're saying. So I think it's important that we think about that and that we keep ourselves and other people in check. The second thing that I wanted to raise was what I consider to be a worrying trend with young people and substances. Now, you didn't specify any substances in your talk, and I know perhaps we're thinking about alcohol, perhaps we're thinking about, illicit substances, but I see a worrying trend amongst young people that are taking caffeine, nicotine. They can walk into the supermarket, buy a bottle of Red Bull, drinking lots of that, some of them ending up in hospital with cardiac arrhythmias because of the amount of caffeine that they're taking. Mountain Dew, drinks like that have a really high caffeine intake. They're vaping a lot. And all of these things are illegal. I mean, they're not outlawed. They're freely available to young persons, and there are no controls where that's concerned. So what are your feelings about that?
Well, I mean, my personal feelings with any substance use disorder, regardless of the substance, is generally when substance use has gotten to a level of being problematic for someone, there is usually some underlying causes that drive that. With, if we're talking about vaping, nicotine, tobacco products, part of it is that it is remarkably addicting, right? It's not just, there's a psychological addiction piece to that, right? And that's true of any substance, but nicotine specifically is one of the most addictive substances on the planet. So part of it is, yes, they're physiologically addicted and they will go through withdrawal if they don't need it, so we're gonna keep using. But there's also the reality that when we're using substances, we're often using them to cope with something else. Why are you drinking 4 Red Bulls a day? Does that mean you're not sleeping well at night? Why are you not sleeping well at night? Do you have insomnia? Do you have depression? Do you have anxiety? What else is contributing to that kind of problem? It is exceedingly rare that I see someone who is struggling with a substance use disorder and they don't have something else underlying it that's contributing to what keeps that substance use going or what elevates it to a problematic level. So, with those things, if we could make them illegal, I think we would, but it's unlikely to happen. And so how do we treat them and how do we encourage people to recognize it? And I'm very aware that my time is up.
No, we do have time for another question here, and I have a couple as well, so we do have a bit of time.
Okay. No, I just wanted to give a follow-up to that discussion as it relates to supply and demand. A lot of times we give attention to reduction of supply, and like what you rightly say, there's stuff that's happening in the family, within the community, that's impacting young people and why they're gravitating to such activities. Because I subscribe to what is called developmental assets. And the more assets a young person has, the less likely they are to gravitate to substance abuse or substance use, or because that's the language that they currently use, but gravitating to using substances that they shouldn't, or sexual activity, or just not attending to school or being involved in wholesome activities. And so a lot of our attention needs to be on those areas and not just on trying to reduce supply or balance both. You know, so I think a lot of times we give too much attention to supply reduction and not give attention to what's happening to the young person that's causing them to gravitate to those behaviors.
I think that's an excellent point, because substance use, and piggybacking off that last question as well, it is so often, there are so many other factors contributing, right? It is the family dynamics, it's what's going on at home, it's trauma, it's anxiety, it's depression, it's not having enough support, it's bullying when we're talking about our youth. So yeah, it isn't a one-size-fits-all approach. We need to be addressing many areas of our society.
Okay, we'll take one more question from the room, and then I will steal time with some questions.
Thank you. I just wanted to sort of comment about this conversation around the use of vaping. And I think adolescents, their developmental task of adolescence is sort of self-identity and moving further away from parents and just trying to figure out who they are. So the use or the experimentation or the checking it out and trying it is quite developmentally typical, and I don't want to necessarily pathologize that. But at the same time, I think we need to be looking at where are they getting it, because they're adolescents, and our job as a civil society is to make sure that they can go through those developmental phases without accessing things easily that are going to cause them significant harm. It's why we don't let them drive until they're 17, drink until they're 18, vote until they're 18, but every 12-year-old I know right now has a vape in their backpack. So we need to think about what are we doing in terms of controlling that product coming into the country and the distribution of that, and what are we doing to the vendors that are selling it?
I think those are excellent points when we're talking about, you know, this isn't an easy approach, right? There's so many different aspects of it in terms of addressing our youth using different substances. Thank you.
Okay, so we'll take the last one, the last one from the room, and then I have one more before we break.
It was more of a comment and an observation, and thank you for raising about the health system. I have a pretty average health insurance policy, and if I injure my leg on a tennis court and I need physiotherapy, I can get extensive physiotherapy under a relatively average policy. But if I need to access something for a mental health condition, that runs out in no time at all. And then when I look at how much access people have to physiotherapy on the island and how many providers there are, and then I look at the same provision when it comes to mental health. There are hardly any mental health providers. Every corner almost has physiotherapy, and I'm not denying that that's a good thing. But I do wonder whether actually we need to start with the insurance system and have mental health properly recognized. And then the providers will follow. Yeah.
I appreciate that, because also, although someone may need prolonged physiotherapy, mental health conditions generally do require longer treatment durations. So when an insurance company says, we're going to cover 5 sessions, I'm like, great, we'll scratch the surface. And then I will do my best in those 5 sessions, but so often it is a much longer duration of treatment because we're talking about really complex things with our mental health and behavioral change.
I could ask maybe 15 more questions, but I will not do that to you, Raquel. I'll ask you if you have any final words you'd like to share with us.
I just want to thank you all for being here today and kind of hearing me out on this presentation. I hope that you take some of this back to your workplaces and think about, okay, what can we do to reduce stigma for the populations that we serve? So thank you guys so much.
So yes, thank you to Raquel. And for those of you who were with us for the earlier session, Dr. Fitzgerald wanted to apologize. Storm blew through Bermuda and that impacted his internet connectivity. So we'd like to thank him for his time as well. Raquel, thank you so very much. We're now going to take a short coffee break and then we'll be back because we have a nice panel and I know the minister has some words for us before we leave here today. But we'll take a short coffee break, compliments of Progressive Distributors Limited, and we'll be back at about 11:15.
Sharpshooter, take a shot. Sight set of it and all and never. Oh, so original. Backfire now, you're shell-shocked. Quiet down if you wanna sound clever. Oh, so original. Yeah, yeah.
Welcome back, everyone. Our next and final session of the conference is a panel discussion on COVID and vaccines, past, present, and the way forward. We have a group of top doctors with us. The panel will consist of Dr. John Lee, Chief Medical Officer for the Ministry of Health and Wellness. We have Dr. Colin Charles, COVID-19 survivor and medical doctor at the Cayman Islands Health Services Authority. We have Dr. Courtney Cummings, Deputy Medical Director at the HSA as well. Dr. Mahantesh Patil of Health City. He's the Senior Consultant Intensive Care and Clinical Lead. He sends his regrets, but we have Dr. Archita Joshi with us. She's consultant in pulmonology and critical care and sleep medicine at Health City Cayman Islands. She will be on the panel replacing him. So if your program shows he was going to be here, we've made that last minute change. And we have Dr. Oliver Kays, urologist at Doctors Hospital. Very impressive panel. And I'd just like to know that at some point during the presentations, while they're being done, we've heard about the lateral flow test that will be done in the Cayman Islands. Dr. John Lee at the extreme left, he will be taking a lateral flow test, and we all expect it to say negative. But let's get the panel going. But before we get into a discussion, I'm going to turn over to Dr. Courtney Cummings. I know you have prepared a few comments that you'd like to share with us.
Thank you, Mr. Mead, and a very pleasant good morning to each and every one. In light of the topic that is for discussion, COVID-19 and vaccine, past, present, and future, I think it's important that I present to you some basic issues so that we make that discussion, I think, better as we go along. I have brought some slides with me, which I want to show you. And those slides, because a picture is worth 1,000 words, I brought those pictures. And I want to thank upfront my colleagues who are sitting here for giving me their time. So I'll be using their time to present these slides. Thank you very much, Dr. Archita, Dr. Charles, and Dr. Keyes. And I'm sure Dr. Lee, having the others give me time, he will give me some time too. Thank you, Dr. Lee. First slide. So I want to make the point to you that COVID is caused by a coronavirus, and the coronavirus was first discovered in the 1960s. And from that time to now, that coronavirus, there are many types of coronaviruses that have come out and we've noted. In the year 2003, we had SARS, you know of that. And then we had, in the year 2013, there was MERS, Middle Eastern Respiratory Syndrome. And of course, in 2020, we had COVID, which you all know of. So the point I want to make here is that the viruses do mutate, they change with time. Hold on, the viruses change, not only they change, because it's an incompetent virus, sometimes they get weaker and they can die out, but sometimes with multiplication, they can change their size and they can change different things. As a result of that, ever so often, we get outbreaks and pandemics and epidemics. That is how it is. And so I want to make the first point that, guess what? The breaking news is that the next epidemic is around the corner. I don't know when it's coming, but it's coming. And so therefore, as healthcare providers, we have to be prepared for the next epidemic or pandemic or outbreak that will come along the way. We may not be able to stop it, but what we can do things when it comes to protect ourselves. And I argue now that the best way to deal with the unknown that comes in is vaccination. Now, I want to quickly talk about the history of vaccines, if you will. And I want to simply say that if you remember, I'm going to use two cases just to make a quick point and I move on. Way back 1,000 years ago, way back then, there was something called smallpox. And smallpox devastated the whole world, Asia, Europe, Africa. In fact, every 10 persons, 3 were affected and died from smallpox. And those who survived had significant amount of scarring because of smallpox. And when smallpox came to the New World, which is where we are right now, in America, North America, the Caribbean, etc., it caused worse problems. It caused significant devastation. And so it was a problem. And there's one gentleman by the name of Dr. Jenner who recognized that the milkmaids who were dealing with cowpox, etc., never got bad smallpox. And so what he did, he got his gardener's son and injected him with some cowpox and exposed him later on to smallpox. And he never got severe smallpox. And that started the whole vaccination thing. And from that was in 1796. And therefore, after that, the whole vaccination drive in the world began. I want to use that as one example. And the second example is that, well, I'll continue that. By 1977, we had eradicated smallpox altogether due to vaccination. And then measles. Measles used to affect as much as 20 million persons a year. In fact, in the year 1980, 2.6 million persons died from measles. But after the vaccination drive, in 1990, 500 and something thousand, 500,000 died, which is a lot still, but much less than 2.6 million. And by the year 2014, only 70-something thousand died. Not only, I mean, 70-something is a lot, but I want to make the point that it was significantly decreased because of vaccination. However, because of the vaccination questions and so on, there's been a rise in the amount of measles cases in the year 2018, 2019, etc. And so my first slide, I make the point that vaccination causes development of resistance against acquiring an infection or the harmful effect of that infection. That's the first point I want to make. But then, I looked at this. I looked in the Cayman Islands, I looked at other places, and I asked the question, but still, persons do not want to take the vaccine, which is what we're here to talk about today. And when we look at it, if you look at that slide there that I've put up on the screen, the blue and the cream, sometimes as much as 80% of persons do not want the vaccine, not because they're anti-vax, but because, one, they're worried of the effects of the vaccine, or two, they believe the vaccine was produced in a hurry. And so the question really is, there's some genuine reasons why persons, they're not anti-vax. That's why they don't want to take it. They're not sure. And today, with the help of my colleagues, we try to help to make them more comfortable and sure of what the vaccine is about. So I want to quickly go through and say that vaccines, what it is really, we inject or we give it orally the germ, an attenuated, a mild form of the germ to the individual. And then the body produces what we call antibodies or soldiers to fight that germ. when that is done, those soldiers remain in the bloodstream or in the body for some time. So should the real thing come in after, they're ready and prepared to fight. That's the gist of vaccines. And so this next slide shows the types of vaccines. What are the types of vaccines? There are several types of vaccines there. There's the viral vaccine, number 1. There's the subunit vaccines, number 2. There's the mRNA vaccine, number 3. And number 4, the toxoid vaccine. Number 1, there are 3 different types of viral vaccines. The life attenuated, meaning we get the germ or the virus, and we partially, it's not dead, we partially destroy the virus, and we inject it in. And that has been useful in conditions such as mumps, MMR, mumps, measles, and rubella. And I spoke about measles earlier. There's another type called the inactivated or the dead, which you use in others, and I put that there. The 2 vaccines, the 2 COVID vaccines, Sinopharm and Sinovac, use that method. And then you have the other type called the viral vector. And then at the bottom, number 3, which I'll jump to quickly, we got the mRNA virus, which is the Pfizer and the, right. In fact, sorry. This screen shows it well. The mRNA, Pfizer and Moderna, see it there. They and the vector, we have Johnson & Johnson, AstraZeneca, and we have the subunit Novavax, and the inactivated, we have Sinopharm and Sinovac. So, as I end, I just want to say now, because I know the question that people have is about the RNA virus. And I want to, maybe in a discussion, but I quickly talk about the RNA. The RNA, when the RNA, simply put, is the actual blueprint. So if you look into that, onto that slide there, you see there's a part called transcription there, the DNA. That's within the nucleus of a cell. And if a cell, because we all have genes, and if the cell has to produce anything from that gene, it unwinds itself like a cotton reel, and that portion of the gene that it has to produce is then produced. But it's then duplicated as the messenger, the mRNA. The mRNA goes in one direction from the nucleus to the cytoplasm. It doesn't go back into the nucleus. And at the level of the cytoplasm of the cell, outside the nucleus, it instructs the cell to produce what it has to produce. And then within a day or 2, it is destroyed quickly. So I make this point to say that when patients receive the mRNA vaccine, the vaccine does not get into the nucleus of the cell. It stays in the cytoplasm, it gives instruction, it is destroyed. And then, this shows it well. So the vaccine is given, the mRNA goes in, it instructs the ribosome or the cells to produce the spike protein or the antigen that will cause the immune system to do its work, is then put outside the cell, and then the immune system now recognizes that, and they mount an immune response against the spike protein. And I hope I made that clear to you as I move quickly. So, moving on. And we looked at all of the vaccines that, well, some of the vaccines that are there in the world right now, and it shows the effectiveness or the efficacy of the vaccine. And if you notice there's about 90-something% for the Pfizer. The Sputnik is about 90-something% also. That's the Jamalea, the Russian vaccine. And down at the bottom, we got Johnson & Johnson and Sinovac. And this, I think the last slide, shows the vaccines that have been authorized or approved by the WHO. So we have Pfizer, I notice you have Sinopharm, you have the AstraZeneca, you have Sinovac. Those are the vaccines that have been authorized and approved by. And last slide just to make the point quickly in terms of the efficacy of the viruses, of the vaccines, you can see it there. It's quite clear there. Okay. No. Thank you for your time. Thank you, Mr. Mead.
Thank you very much, Dr. Cummings. I don't know if anybody else on the panel has any comments that they want to jump off with, or if we could get into a discussion.
We can proceed with discussion.
Okay, so Dr. Lee?
Thank you. So thank you very much, Ben, and thank you. If I've gotten your opportunity to say it now, you've done a really great job, so thank you very much throughout the conference. I just thought it's worth saying that as we look to the future, there are some really exciting things that are coming along in the management of COVID-19, which some of you will be aware about, but I feel it's important to mention. There are likely to be second-generation vaccines that are going to come out, which will target different parts of the genome of the virus, and therefore will not necessarily require the or will sort of be able to continue to give benefit even though the spike, there's been a lot of variation in the spike protein. So that's really good news. And also, some of you may have seen in the news that there are antivirals coming out that are undergoing large trials now. These are room temperature tablets, foil wrapped, that GPs will be able to give out to people who may have been exposed and will be able to cut the number of people becoming seriously unwell. So some good things that are coming. I just actually also want to go back to the first day and talk about the environment, because I feel it's so important and we cannot lose sight of this. Disease has always been caused by the density of humankind. We know that if you're over there in the corner and I'm here, I ain't going to catch the disease from you. So it's about the density of humankind. And that gradually became increasingly known in the 19th century, along with the requirement for fresh water as a fundamental necessity for life. Of course, we know about hygiene, the requirement for food, poverty being a big, big issue in the causation of disease because of lack of access to fresh water and good food, and also the issue about density of populations. But we have seen so much that the numbers of human beings and the environmental pressure that human beings are putting on this planet are causing these things to come out more and more. So I would please ask for people to bear that in mind as they're going about their lives, to have it in the back of their minds. The containers we throw away, the food choices that we make, the other energy choices we make are really, really important. That's the end of my comment, but I think the camera might focus on me for a little bit because I'm now going to do a lateral flow test so that you can all see it being done whilst I allow the other questions to go on. Okay, thank you, everyone.
We do hope that we're going to have a free-flowing discussion, so if there are any perspectives that anyone wants to share, you can jump in and get going and we can have the discussion. Dr. Case?
I'm happy to jump in there, Ben. Thank you very much for the organizing committee for allowing me to speak on the panel. And I watch in interest as Dr. Lee does his first test. I've done 150 lateral flow tests in the last 12 months, and all of them were negative, thankfully. If I take you back to March of last year, I was busy packing my bags, ready to relocate to Cayman to work at Doctors Hospital and set up what we hope to be one of the premium urology services in the Caribbean. 2 weeks later, I'd unpacked my bags, rescinded my resignation, and was busy working on the surgical wards, where an influx of COVID patients were coming in. Surgical services were suspended. We were having to make very difficult decisions around triaging which patients got what care. And ultimately, the COVID presence on our ward was so high that I switched from being a urologist to being a generalist. And in that time, we were unvaccinated, we were minimally protected by the PPE we had. I saw colleagues going to ITU, and it was incredibly scary. Since then, 12 months on, we have vaccinations, we have protected staff within the hospitals, we have policies that help protect us in our day-to-day work, we have a vaccinated population, which means we're reopening services, but we've got an enormous amount of backlog of work to do. My job really has covered all three facets of the areas, including public health, which Dr. Lee's involved in, and testing, through to making sure it's safe for patients coming into the hospital and keeping my staff safe, through to my day-to-day job, which is really men's health. And what we saw from the outset, and has been repeatedly shown over the data, is that men are at higher risk of more severe disease from COVID, which relates to higher admissions to ITU, and admissions to ITU, unfortunately, are linked to higher mortality. From my perspective, as what I understand of vaccination programs, there's a poorer uptake among male populations. And obviously, there's an encouragement across every domain and sector for us to try and get everybody vaccinated to help us move towards reopening both in Cayman but globally, so that we can continue to do our work and return to normality. My final thing to say about men's health really is that there is evidence that COVID and severe COVID illnesses, and the gentleman on my right will certainly attain to this in a minute, I'm sure, about his own personal experiences, but we are seeing that men who contract COVID have poorer outcomes in terms of their cardiovascular disease, pulmonary disease, but also in the world I work in, it's sexual dysfunctions, infertility rates, hormone disturbances. Now, some of this is recoverable and reversible, but it's also preventable. So the vaccine is the first step. But if these events do happen, and we're seeing some cause and effect where we can identify virus particles in biopsy specimens, and to understand whether that means that the virus is responsible or it's a systemic insult of that viral effect that's causing the longer term effects of the disease. So I think that's my few minutes that I've eaten up for Ben. I'm happy to take any questions from the rest of the panel or move on.
Okay, we can keep moving forward. And I know we're talking about vaccines, past, present, the way forward. Dr. Charles, if I could just ask a question, I'm sure you've been asked this a million times. How has your experience helped you to be a physician and better understand what patients would likely be going through?
Sure. Thank you very much. Thank you all for having me. I have thoroughly enjoyed these presentations over the last 2 days. The high-level academic content will help us all as healthcare workers optimally manage and improve our management of our patients, as well as educate others. And that perspective is great. But there's also an additional perspective that we all can utilize that can help us in our physician-patient and caretaker-patient experience. And that is the perspective of the patient himself. I myself, my perspective on this as a physician has now been colored very vividly by my own experience by contracting the virus. It was just 7 months ago where I was hospitalized with severe symptoms. And we as physicians know up to 71% of severe presentations of COVID will experience some type of acute respiratory distress. But do we actually fully appreciate what the patient is experiencing? In my case, the best way I can describe this is akin to someone physically holding me underwater where I cannot breathe. And that perspective is very different as caretakers when we see things through the patient's eyes, through the patient's experience, where we can empathize with the patient. We all know that fatigue and generalized weakness can occur up to 84% of severe symptomatologies. In my case, it was me feeling so weak, so out of energy that I couldn't do anything for myself. I would be lying in bed and not being able to have the energy to even open my eyelids. For days, weeks, I was completely dependent on others. We know that insomnia can be one of the symptoms as well. I went for days, 4 or 5 days, without even having to sleep for 1 hour. It was horrific. We know that there are gastrointestinal symptoms that one can experience: vomiting, diarrhea. From an academic place, we have a good idea as to what that is like. In my particular case, in less than 2 weeks, I lost more than 25 pounds. I was in a catabolic state and wasted away. And it is these type of experiences that help me to empathize with my patients now. It's these types of experiences that help me to speak with others who may be on the fence and still not quite sure what are the best options for them to protect themselves as well as their family members. I think we as healthcare physicians, if we can hold that perspective so we can express that to our patients, as well as handle them with the type of care that is needed when going through these type of severe and horrific symptoms and experiences. With that said, I think now would be an appropriate time to just express my gratitude to my HSA family, who showed up and showed strong. Even though I was overseas, they did everything, moved mountains to make sure I received the best care that I could. I'd like to give special thanks to the executive committee, including Dr. Jefferson, Dr. Cummings, and all the medical staff, and as well as allied staff of the hospital, all prayers and positive thoughts that came my way, because those were the very things that saved my life when others didn't have those resources and that help and are not with us. So to sum up what I would have learned from my experience, and to be very candid with you, going through what I experienced, it was so traumatic that you want to avoid going through this at all costs. And the vaccine, it gives you a best possible chance of protecting you from severe presentations and symptomatologies, as well as death. Additionally, this is not simply about your personal choice. The reality of this virus is that it affects not just yourself, but every and anyone you come in contact with directly or indirectly. So that consideration should be made, especially if you care about your loved ones. So that would be my, this is some total of my experience.
And I would say thanks for sharing that perspective. The more we hear about it, because in the Cayman Islands, we've been fortunate to have been insulated from the worst of it. So we can go through the entire day and not meet anybody who can share the experience that you did. So thanks for sharing that, Dr. Charles. A question I'll ask to the panel in general, and whoever wants to come in on this first. So we've been through the past 18 months of the pandemic. How confident are you today? And I'll ask Dr. Charles, we'll skip you because you're very confident with knowing the symptoms, but treating a patient with COVID, say, compared to when we first introduced lockdown measures last year?
I think I'll answer this one. Of course, we in the Cayman Islands have been really fortunate. We've not had many cases or mortalities, and I can understand what Dr. Case just mentioned about, half the hospital or more than half the hospital being filled with patients. I think the first patient we detected on island was actually my patient. I'm a pulmonologist, and I was involved. I can't say it was my patient to begin with. He came with cardiac symptoms and was in the critical care unit, and possibly was incubating or this virus, and presented with respiratory symptoms down the line. And of course, I was involved in the care. And from that experience, at that point in time, being unaware of treatment options, this was in early March, and not having a whole lot of experience with treating this kind of virus, although the supportive care remains the same for any acute viral illness or ARDS, but not having any treatment modalities to treat the infection per se, the stress of dealing with the staff who may have been exposed, to address their symptoms, to address their concerns, to isolate them, to go through that entire rigmarole of establishing protocols. Although we had already started the process 2 months ahead when we started hearing about, I look after infection control in my hospital, so we had already started setting up protocols. But it's a different thing to do it in theory and a very different thing to do it practically when you have the problem at hand and you see your colleagues who've been exposed, you see yourself, you're potentially exposed. You see other individuals who may be at risk from the families of the people whom you work with, because they may have been indirectly or secondarily exposed. So it is a major task, and I think over the year we have evolved, not just, I wouldn't say we, but I would say from the experience the world has gone through. I think we have learned, and that experience itself, we had to shut down our hospital for 2 weeks because we did not want this to spread to the community. And we did not want any of our staff to be further harmed by exposure. The amount of planning we had to go through. I still lived, I don't like to look back into the past, but thinking about those days, sleepless nights and working 24 hours and being on the phone, any staff calls, are you symptomatic, are you having this, that kind of anxiety that everybody went through was very traumatic. And I think at this point in time, we are much better equipped. We know of what works and what does not work. We are not speculating as much. Science and research has taken us way forward in the management of this infection. And I think we are definitely better equipped. We also have a lot of protocols in place. We have a lot of public and private collaboration on this island now, which is very encouraging, which allows us to interact with our colleagues, have a national task force where we can interact and decide on treatment modalities. How do we go ahead if there is an outbreak or we exceed hospitalization capacities? So I think that we are in a much better situation, Ben. Yeah.
Thank you very much, Dr. Archita. Dr. Cummins, any perspectives that you'd like to share on that?
Right, Dr. Archita went through an extensive comment as to what has transpired. The important thing to say, in addition to what Dr. Archita said, is that we have new drugs. I remember a year ago when everything was just symptomatic and you hope for the best. Prayer is good, but we still pray. But now we have drugs we can use. And the further point I'll make is that what I like about, I don't like COVID, but what I like about the whole thing is that every day or week changes occur. It's a live document, a live issue. And I remember that in August this year, when you look at some of the protocols for managing COVID, the Infectious Disease Society of America, the CDC, they did not have what now they call post-exposure prophylaxis. So over the last month now, they're talking about anybody who possibly been exposed, you can give them a treatment. What am I saying? I'm simply saying that the treatment is better. I'm agreeing with Dr. Archita. I'm simply saying that things are getting better. And tomorrow is going to be better than today. So I think there is hope. There's hope. We continue to use all of the measures that we advocate, social distancing, wearing a mask, hand washing, all those things. But treatment is on the way right now and will continue to improve with time.
I think when we first heard about COVID and locally we went into lockdown measures, I think we'd be mortified for half a dozen of us to be sharing a platform like this. It shows how far the knowledge and understanding has come in such a short time. Let's look forward an equivalent amount of time. What do we think it's going to look like?
Well, I'll jump in quickly there. Let's go back to Dr. Cummins' slide about why people didn't take the vaccine up originally, and one of the main causes was the unknown, wasn't it? It was the idea, I don't know how well evidenced this vaccine is. Well, we're 12 months on now, and we have great evidence that these vaccines work. They're in line with the other vaccines that have been produced for other diseases before, and then behind it, more vaccines have been developed. There's now a new malarial vaccine that's coming to the fore. So this is the way we try to beat these type of conditions alongside all the other measures that Dr. Lee's mentioned, as well as our sort of public health measures. Perhaps I'd sort of open questions to the floor. From my experience, the data around the serious adverse events from vaccinations is incredibly low. I wonder if anybody's got a comment to sort of promote better uptake now that we're 12 months on with these known, particularly RNA-based vaccines we have.
I think one of the, I'd just like to make a point here, and I completely agree. One of the ways we feel a little safer and better equipped now in healthcare is because most of us are vaccinated. And we feel more confident, if we were to have an outbreak or a surge of patients in the hospital, we are not going to be that worried about our colleagues falling sick and not making through the infection, or we're not worried about ourselves or our families so much now, because we have data to show that the rate of hospitalization or admission to critical care units is far lesser, even though you may still acquire an infection with the variant, but the rate of serious infection is so much lesser or lower in individuals who've been vaccinated that they may have only maybe mild symptoms of flu-like illness and get away with it. And so I think it's a small price to pay, to get a vaccine to protect yourself and to protect your loved ones. And I've been asked this before, saying, how does my vaccination affect others? I mean, am I going to infect others more? The answer is yes. Vaccinated individuals, even if they get infected, are not going to shed the virus very long. They are more likely to be asymptomatic, and therefore they will not transmit the infection more. So being unvaccinated does make you a risk to other individuals who are more vulnerable, those who could not receive vaccination for some other reason, or those individuals who may not mount an adequate response to the vaccine, even though they may have received it because they are immunocompromised. So vaccination is, of course, for your own protection, but it definitely helps the society at large. It helps your loved ones at home. It helps your children at home. And I think a year down the line, that is one point I did not make. The fact that we've taken vaccines now gives us a lot more confidence in our own safety. Somewhere in our mind, that thought is always nagging. I'm going to I'm going to intubate a patient. I'm going to do a bronchoscopy on a patient who's got a collapsed lung and has a COVID pneumonia. Am I safe? Am I, ready for it? And that always plays in your mind, obviously. And so if we are vaccinated, we feel more confident. There's a role for boosters coming up now, and I'm sure that will help us all in the medical community. And I think that in itself is a big change in our mindset as well, as a healthcare community.
Dr. Lee, were you trying to get in?
Yes, thank you. I think people obviously have been scared throughout this pandemic, and for absolutely understandable reasons, we all were. The pandemic came across the world a little bit like a tsunami. It was a sudden onset, dramatic change in all of our lives, and that causes fear for everyone. And we're all still stunned by it. There's no question about that. But looking to the future, I don't think we're going to have the same cliff edge, as so many people have said. And in a very small view, if you think back to 4 weeks ago where we were and where we are now, everybody has come to terms with the fact that we've got community spread of COVID. So this is the gradual process as we move forward. People who've been able to travel, I had to travel for family reasons, Dr. Keyes' experience from the UK. People who've been able to travel have been able to see countries in different stages of this process. And life will move on, and life will improve, and we will continue to do the things that we love to do or get back to doing them. There might be adjustments in the way we do them, but I want to caution people not to think that it's going to suddenly get better. It's going to be a gradual process over the next year to 18 months or so. But it will definitely be a journey that we'll look back upon, obviously, and all say, wow.
Okay, I'll be opening up to the floor for questions if there are any, but Dr. Lee, you started off taking the lateral flow test. What is the percentage reliability of these lateral flow tests? Do they provide false positives as well?
Yeah. So lateral flow tests, it depends a little bit on the state of infectivity that you have. So they're somewhere between 50 and 80% as effective as PCR, sometimes a little bit higher than that. But they're far, far better than no knowledge at all. They're much better at picking up infections where there is a high viral count, and they're also better when you use them sequentially. And that's exactly what we're hoping to do by the plan that we're developing now, and which the Premier and I have begun to, and other people have begun to share, that we will use them, we will hopefully flood the country with them so that you can use them whenever you want, whenever you're going to see somebody that's vulnerable, whenever you're going to do something which you think is a slightly at-risk thing or you don't want to put people at risk, you'll be able to do a lateral flow test. In organizations and institutions, you'll be able to do them on a daily basis if there's somebody in that particular environment that you know has been infected. And then if you feel that the infection rate has dropped in that your particular environment, then you'll be able to reduce them probably to twice weekly, maybe even to once weekly, but I suspect we'll probably stay at twice weekly. So it's a question of continual monitoring in order that we can early identify anybody might cause a problem. They can come out of the scenario and then let everybody continue with their lives.
Thank you very much, Dr. Lee. We have a question from someone in attendance.
Good afternoon, panel. Excellent discussion. This question is for Dr. Charles. Dr. Charles, you contracted severe COVID virus infection 7 months ago or about. Have you fully recovered? If not, are you improving?
Thank you for that question. I'm very grateful to be in a state where I can function normally on a day-to-day basis. With that said, I'm still experiencing long-term sequelae. My pulmonary function is yet to improve completely, and that can last as much as possibly up to a year, if not longer, to fully recover, if I fully recover. There are neurocognitive and psychiatric aspects that are also a part of it. In my particular case, experienced heightened levels of anxiety, which can occur, and as well as my overall conditioning. While I was hospitalized, as I said, I was in a catabolic state, and I lost quite a bit of weight. But subsequent to that, due to the inactivity and some of the medications, I gained quite a lot of weight. So my overall conditioning is still yet to be improved. With that said, I work diligently every day to improve my condition, and I'm doing quite well. But there are still some long-term challenges that I still have to overcome.
And we'll open up for more questions. But along that line, Dr. Charles, what advice would you have to someone who, say, had a mild case of COVID and are wondering now, and their head is going crazy, and we do what we call Dr. Google, check for every possible symptom, and worrying about what their long-term or medium to long-term situation is?
Well, in terms of experiencing mild symptoms, fortunately, majority of the cases of persons who contract COVID are asymptomatic or experience mild symptoms. With that said, speak to your physician. We have an excellent system in place where we have a flu hotline where persons have any questions or queries. They can contact that COVID hotline, and they can get a verbal assessment and then instructions as to what to do from that assessment. So I think maybe Dr. Lee or Dr. Cummins, you guys can speak more to that, but that would be my suggestion.
Dr. Cummins or Dr. Lee, did you want to pick up on that, or?
Well, just following up with the established COVID hotline that we have. I think the system that we have is very efficient, very thorough, and I'd recommend patients, if you have any questions or concerns, give the flu hotline or the COVID hotline a call.
Someone viewing remotely, Dr. Cummings?
Well, I was going to say that, so COVID is a relatively new condition, and we're just a year and a half, maybe just under 2 years into this condition. And so we don't know the long-term sequelae, as you put it, that will occur. But in the past, if we look, and history is always a good teacher, some of the viral syndromes in the past have left people with different things. But if you go back to 1918, and none of us was there then, I hope. I know, better, I said hope, I meant no. That Spanish flu killed 50 million persons, and it caused devastation around the world. But then people recover from it, and I don't want you to be careless now. We're going to recover, but it will take time. And people had subsequently a number of side effects. Some were in the catatonic state, but people eventually emerged from it. So I think, and again, I have to preface my comments by stating that it's a new disease. We don't know what and they call it the long haul COVID. We don't know what the long-term effects are going to be, but I believe it will get better with time with regards to some of those symptoms that persons have, the chronic fatigue, some significant lethargy, but I think it will get better with time.
That brings me to this. What level of concern is there in the medical community that more and worse mutations will still come off the virus, especially in countries unlike ours that has a fairly good uptake, but countries with low vaccine uptake?
Right, so I could take that. So yes, there's a lot of mutations. In fact, there's one that came out a week ago, the R1. And we said that in our initial presentation, that the virus will mutate. It will continue to mutate, and it's mutating. Some mutations are going to be of significance, others will not be of significance. And in fact, I have a question here as I answer this. Someone asked the question, how is it that then, if you are vaccinated, why you catch the disease still? Well, because one, and we know that with time the antibody level or the defense, one's defense may wane, and that may put you at some risk, better than if you were not vaccinated anyhow. And two, because of the different strains that are coming out. And that's one of the issues that we have to be dealing with. But I say to you that at the end, we have to consider it this way. If there's no virus, there's nothing to mutate. This is why we need to have collective defense. If I were to show you a picture with one person who's infected, that one person can affect another 4 or 5 persons. But if the 4 or 5 persons around are immune, either they recovered from the disease or they're vaccinated, same as immunized, the virus can't jump to them. So the only place the virus has to go is to die. So if you have a significant amount of persons vaccinated, it will die out. If you got a significant amount of persons in the world vaccinated, it will die out. If it dies out, there's no mutation.
Okay, so brings me to this question, someone viewing. Is it true that the vaccine distribution itself will make the virus mutate to protect itself? And the person puts this caveat, I'm fully for vaccines and my whole family is vaccinated, but my anti-vaxxer neighbor keeps saying this. How do I refute?
A bit of a poisoned question, that one, isn't it? But I think if you're trying to produce evidence for people that these vaccines work, it's around the length of studies that we're now getting showing that the efficacy of the vaccine from being hospitalized in any age group proves that it's working to stop that from happening. It may not stop transmission, but it will stop you getting very ill. The second thing is, if you have a vaccine, we can measure antibody levels, and after vaccination, they are 10 times higher than contracting the disease itself. So even if you've contracted the illness, you should still get yourself vaccinated. And the third point around this is the boosters. So if you have lowering levels of antibodies, you require boosters from time to time to elevate your antibodies to suppress the viral infection and its effects. And that comes in line with our general principles of annual flu testing and flu vaccinations in general. And thereby, we'll try and identify these variants early enough so that you're then tweaking the vaccines to be optimal. I think that answers the question.
Can I just quickly add to what was said, that as far as I'm aware, mutations do not occur as a result of vaccination. The mutations occur as a result of the virus itself being an incompetent virus. The enzymes make mistakes all the time. So I've not read anywhere, so I think it's a good question, but the truth be told, it is not as a result of the vaccination. The mutations occur because the virus is what it is.
We will be going to the floor in just a bit for some questions, but Dr. Lee was just showing that he has completed the test. I won't ask for the result, but you haven't been running. So we'll assume the result. And before I toss to you, on this, when lateral flow tests are being used widely in the community, How will people report the positives, and how will this be handled?
So I'm pleased to report that my test is negative.
I was just about to run from here.
Dr. Keys is particularly happier to hear about that. The lateral flow test reporting, some of you will know, but just to reiterate, that SARS-CoV-2 is a notifiable disease in this country. And as such, it is a legal requirement for anybody with a notifiable disease, whether you are an ordinary resident or whether you are a healthcare provider, to report those positives to the medical officer of health. What we hope to do is if somebody is positive, they would ring up the flu hotline or contact their healthcare professional, and we will arrange for them to have a PCR test to check the result, and then we'll give them further advice about isolating. That's how it will work. We won't, initially, certainly, we won't be recording all the negatives because there are going to be thousands and thousands of those. But naturally, we would anticipate that any organization that is conducting an organizational test, such as a school or an employer, that they would keep a record of the negatives because they want to check that it's being done. I just thought we talked about boosters just now, if I just quickly mention that although the booster program is open to certain categories, initially the clinically extremely vulnerable, and then by age group from Monday for the over 70s, healthcare providers, because of the demands of their work, are able to come to get their boosters at any time during the program whilst it's running. So we're not holding them for any particular time. If you can have time away from your work, you can attend to get the booster.
Thanks, Dr. Lee. Let's take a question from the floor.
Okay, I have a couple of little things to say. I just got my booster vaccine about 2 days ago. I don't have any symptoms like pain or anything, just a little pain where they gave it to me, but nothing else. And I don't have no really bad underlying disease, but I just went because they was giving it and wasn't much people there. Anyways, I just wanted to ask Dr. Charles, what did he felt when he just started getting sick?
Oh, thank you for that question. My initial symptoms were very subtle at the beginning. Started with just a simple runny nose, but they progressed very quickly. The following day, I had a productive cough. The day after that, I had fatigue and muscle pains and weakness. And the day after that, I had labored breathing. And that labored breathing, in terms of my pulmonary involvement, progressed significantly overnight. When I initially went to the hospital and was tested positive, I was admitted for 2 days and then discharged. I would have gotten home maybe about noon that day. By 11 o'clock that night, and I was fortunate to have a pulse oximeter on me at the time, monitoring my oxygen saturation levels as well as my heart rate. And by 11 o'clock that evening, I essentially woke up out of bed, out of sleep, deep sleep, gasping for air. And I was able to exhale, but I could not inhale. I could not breathe in. And I could not speak. And I called the ambulance. Actually, it was a colleague and friend of mine, dear friend, Dr. Bernard, who was also a physician, who I called, and he came to my rescue and took me to the hospital and essentially saved my life. But it was, those were my initial symptoms.
Okay. I have 2 persons that I know, not here in Cayman, one in Fort Myers and one in Nicaragua. That one of them in Nicaragua, she died. She was going to the United States and she went and did her test, and it came out positive. And looked like a couple days after, she was gone. She was in her 60s. And then my older sister, that is 83, a couple months ago when it had kind of just started, she got it. But then she recovered. But I'm not sure if it's because of that, her brain is not working that, she's not really Alzheimer, but, so I don't know, if it really affected her brains or what, but she said so.
Is that something we've been seeing, or? hearing in relation to this? As we get set for another question, I think I saw a few hands on this side of the room. So there's a question coming up here.
So I just wanted to thank the panel. You basically had an amazing synthesis of evidence that should, I think, be compelling to people. But, you know, just the comment that I really wanted to make is that when a disease was faced by human populations in the past that devastated the civilization, that people made a commitment to eradicate it. Do you really want this disease to become endemic? I think you've given such good evidence for that, that perhaps that we can convince 100% of everyone. Why go for 50 or 60 or 70? No, there was smallpox, and imagine that that used to affect individuals, which is why. And then it killed everyone. Do you really want, and you know now that it's mutated. Okay, it can mutate repeatedly. You already have how many variants? Well, perhaps that's just because now we know how to do it. With smallpox, we didn't. Okay, but this is a different beast. This is a different animal. I mean, how it came to be, okay, as virulent as it is, okay, is still, I mean, in some quarters, reason for debate. But it should not be. The physicians and health people, they don't do this for their own good. This is a profession, and profession is a calling. So thank you all of the physicians, and thank you for giving us that perspective that 5 days without sleeping. Okay. People imagine what happens when you go 5 days without sleeping, and gasping, okay, is probably the one way that people don't want to die.
Thanks, and I think it's important, while we thank the doctors, the countless number of nurses who've been on the front lines with the doctors as well, we should thank them as well. A question?
Hi, in terms of the booster vaccine, I just wanted to confirm, is it the same dose that you get as the original 1 and 2? Yeah, great. And then will Cayman be getting the booster vaccines with the flu vaccine combined, or are we just going with a straight booster?
That's not currently planned. I don't think the flu vaccines have arrived yet. So.
But I think in the UK, do they do a mixture together, combination?
I know they're doing a mixture in the UK.
Yeah,
we have not planned that so far.
Okay, cool. Thank you.
Okay, if there are no other questions from the floor, we'll take one last question, and then I'll give each of our panelists an opportunity to share some closing thoughts.
My question is very simple. Will each of the participants of the conference be getting the test to take home?
I wish we could provide that. I think the first lateral flow tests of this current order are arriving on Monday on the British Airways, and there are quite a few coming thereafter on flights thereafter. But it is obviously new to these islands, so we are working very hard to arrange a scaled sharing of these. And our first target group will be the 5 to 12-year-old groups in schools, obviously, because they can't be vaccinated, and we have a current outbreak within the schools, as you know, so that will be the target group. Dr. Keys absolutely rightly pointed out to me that we need to make these sufficiently available so that if anybody gets any symptoms, they can test themselves, because although some people are asymptomatic, we really want to, if the more symptoms you have, the more likely you are to spread. We really want to pick up people with SARS-CoV-2 and pull them out and isolate them before they spread. So we're hoping for everybody, sharing the knowledge here so that you understand how best to use them.
Patient-centric from provider-centric?
Well, this is for households, homes, people that run houses and look after other people to look after everybody by using this extra tool that we hope to share.
And Dr. Lee, while you have the mic, any closing thoughts?
I'm good, thank you. I talk far too much.
Okay, we can come on down the line, Dr. Case.
Really just 2 points. One is I work in healthcare because, you really can make a difference at an individual level. I think people assume tomorrow is always going to be okay, but behind the scenes, that assumption is backed up by some brilliant science and some huge investment. And we're seeing the benefit of that now, and that's in the form of testing or vaccinations or what we're able to do on the ground. To your point about the lateral flows, just as an example, we had a gathering when I went back to the UK. We had 50 people, sort of 10 families, and we all tested ourselves to make sure that we were negative before we got together. We knew there was spikes around us in bigger festivals, but we knew we were safe when we actually met for a weekend. So I think this is going to be a huge step forward.
Dr. Charles?
Sure, thank you. I'll just simply say and express my sentiment that life is so precious. We as healthcare workers are here because we understand the value of how precious life is, as well as its fragility. After experiencing this virus firsthand and experiencing the horrors of it, my wish or my hope is that no one on this rock has to go through this. And the vaccine is one sure way to significantly lower your risks of going through this. So I hope that persons will be encouraged to do so, and so that we all can breathe easier.
Dr. Achita?
I think everybody's made their point, and I couldn't say anything further after what Dr. Charles just said. I had a few thoughts in my mind. But I think we all need to understand that vaccination is not just for yourself. It's obviously for yourself first. It's for your family. It's for people who you may have come across or your loved ones. It is also for your healthcare providers. It is for us not to get overwhelmed, to be able to provide services that will be needed. Besides just COVID-19, there are going to be heart attacks, there are going to be strokes. We don't want to overwhelm our healthcare system so that we cannot provide care to those individuals who need it for other reasons. So please do it for the country, do it for yourself, and do it for your family. Thanks.
Dr. Cummings.
Right, yeah, thank you. Well, just want to make a point that recently, in fact, the last 2 weeks, there's a new medication, an oral medication that is out to potentially treat COVID. Wouldn't call the name, but what I want to say is there's hope. With all the gloom and the doom we speak of, there's hope. But guess what? If you're dead, it can't help you anymore. So therefore, I encourage everyone listening that, as my other speakers have said, you probably need to protect yourself with the vaccine because, again, if you're not around, those new medications that are coming on stream will not help you. There's hope. There's hope.
Thank you very much. That was Dr. Courtney Cummings, the Deputy Medical Director at the HSA. Also on the panel, we have Dr. Archita Joshi from Health City, Dr. Colin Charles from HSA as well, Dr. Oliver Case from Doctors Hospital, and Dr. John Lee, the Chief Medical Officer. Thank you so very much to each of you for sharing this morning with us. Very useful discussion, very informative. Thank you so very much. Now, I do have the distinct pleasure of welcoming the Honorable Sabrina Turner, the Minister for Health and Wellness, to the podium for some closing remarks. But before I hand over to Minister Turner, I want to say thank you again for your leadership and support I know you've been here pretty much every day, ensure the conference took place, even while ensuring your ministry does what it needs to and has been working double time. Thank you very much.
Thank you. And I'm happy that I was able to understand the importance in my ministerial role to carve the time out to definitely be a part of this conference. I am breathing easier for a number of things and reasons today. First of all, Dr. Lee is negative. And breathing easier to know with the panel of experts and all the presenters that we had presenting to us over the last 3 days definitely can reassure that our jurisdiction, the Cayman Islands, is prepared, and we definitely are able to manage what we can and to the best of our ability any COVID patients that presents themselves, and we definitely have extended ashore thanks to telemedicine and technology. Should additional information and support is required, we have made those connections. The 12th annual Cayman Islands Healthcare Conference comes to a close. And I trust it has been a very informative 3 days for everyone who has participated, either as a speaker, attendee, or viewer. I was able to sit in on a number of sessions, and I'm happy, I have to repeat that I made the time to attend, as they were very insightful. As a former member of the nursing profession and the current Minister of Health and Wellness, I was interested in learning more, not only about the scientific research that is being done surrounding COVID-19, but also the personal experiences that our healthcare professionals and workers are having in their private practices or medical institutions as they encounter patients. Everyone in the health industry, in my opinion, are everyday superheroes. And one thing we have to take away from them, and remember, they are humans too. What I've learned from the data and the anecdotes and stories that were shared is that from our youngest to our elders, we have all been impacted by the COVID-19 pandemic. It has affected us in a variety of ways, particularly in the area of our mental health, whether diagnosed or unidentified. The fact that the experts we've heard over the past 3 days have confirmed that COVID will be with us for the foreseeable future means that we need to find ways to manage the effects of COVID on our lives and gain the tools necessary to help us adapt and breathe easier. As the conference theme says, in the pandemic era. I am also grateful to our community and that they have proven that they have the resources such as this conference and the expertise of diverse medical society that can help us navigate through these challenging times. I want to take this time to remind everyone out there who may be having difficulty time coping that you're not alone. There is help available. All you need to do is ask. Don't be ashamed or afraid to ask for help. Our mental health hotline is 1-800-534-6463, and it is manned Monday to Friday, 9 a.m. to 5 p.m. However, we are working tirelessly to get volunteers so that our hours of operation can and will be expanded. These are not normal times, but we have to find our own personal normal so that we can all thrive. I want to thank our sponsors and exhibitors for their support and once again helping us to make this conference a great success. I would also like to take this opportunity to encourage our local and international speakers for so graciously giving up of their time to educate us from each of their unique perspectives. If you've missed any of the sessions or would like to see them again to really reabsorb the information, remember They can be viewed on CIG TV's YouTube channel. And I would encourage each of you to share what you've learned over the past 3 days with your friends, families, neighbors, and co-workers. The Ministry of Health and Wellness is already looking ahead to next year's event, and I encourage you to share your feedback and ideas in the survey that we'll be sending out to you next week. This will help us shape the theme of our next year's event. However, I think we've possibly found a theme or pretty much a topic for next year's event. I'm hearing mental health. I'm also hearing insurance. With the long-term mental health facility that's coming on stream, this validates this theme even more. So I'm excited. Yes, I'm planting a seed of an idea. And I'm also of the view that with COVID and persons having to be subjected to isolation and quarantine, conversations have been more prevalent in our day-to-day discussions surrounding mental health. So, easier access to mental health care through insurance legislation, and the modernization of our laws and behaviors are vital to moving forward. Tomorrow, Sunday, is Worldwide Mental Health Day, and the objective is to raise the awareness of mental health issues around the world, and it's no different right here in the Cayman Islands, and to mobilize efforts in support of mental health. This year's slogan is, "Mental health care for all. Let's make it a reality." Depression is a leading cause of disability worldwide, and globally, it is estimated that 5% of adults suffer from depression. Globally, 1 in 7 10 to 19-year-olds experience mental health disorders. 1 in every 100 deaths is suicide. It is the 4th leading cause to death of young people ages 15 to 29 years. COVID-19 pandemic has had a considerable impact on people's mental health. And that is why I will plant that seed for consideration, and I'm excited to know what the survey reveals. I look forward to seeing you here next year, and thank you for joining us. Enjoy the rest of your weekend.
Thank you very much, Minister Turner. As I mentioned, she has been juggling everything else and being here for a number of the sessions. So thank you very much. I'd like to say thanks to those of you who've been viewing on the various platforms that we've had, if you've not been able to be here. To those of you who were able to be here in person, thank you as well. To all of our panelists, speakers, presenters, a big thank you as well. But I'll ask those of you, if you're viewing virtually, you can join in as well. Those of you in the room, let's give a big round of applause to the team who's been working hard behind the scenes. They were planning for fully in-person as the situation changed to do a hybrid, so I want to thank them for that. And before I go, for those of you needing CME credits, the certificates will be made available on the website. That's healthcareconference.ky. I'll repeat, healthcareconference.ky. Thank you again, everyone. Stay safe and have a good remainder of your day.